Now, my job here is to present you material that is board relevant and board topic. I'm not here to teach you neonatology in all of 3 hours, as neither are any of the other speakers, but we're here to present you and point out all of the possible test questions and what the board likes. So moving forward with that, we do have to spend the first hour, first 30 minutes at least, going over some less than exciting things, terminology of which the board likes. For instance, live birth. What is a live birth? A live birth, they will say, it's a complete expulsion or extraction. There has to be a heart rate. There has to be some breathing, some movement going on. If you get a case scenario or a little scenario and there is no movement on there, then it's probably fetal death that they're getting at. And fetal death, of course, is before expulsion and no evidence of life. Infant death is one they like. Infant death, knowing the definition, is birth up to but not including 1 year of age. Gestational age, you all know very well, is the number of weeks from the first day of the last normal period. And birth weight, we always express in the nearest gram. Now, AGA and SGA, you guys know this very well. AGA, just so you remember on the test, 10th to the 90th percentile for given gestational age, and SGA, weight less than 10th percentile, and LGA, greater than 90th percent. Now, sometimes in the question or in the vignette, they may just use low birth weight, very low birth weight, extremely low birth weight, or ridiculously low birth weight, so that I put those in there so that if they say, hey, this is a low birth weight infant, think to your, 25, less than 2,500 grams, very low birth weight, less than 1,500, et cetera. And it's not gestational age dependent. Now, term, this gets a little complicated as well because the board likes to have you to know that the first day of the 38th week to the last day of the 42nd week. We often, throw around, they're 37 weeks, their term. Well, not on the board. It has to be the first day of the 38th week, and post-term is not until, as you see there, till the first day of the 43rd week. And preterm, born on or before the last day of the 37th week, so before 38 weeks. And just keep that in mind because it can get a little confusing and you don't want to miss something like that. Now, neonatal mortality, they will throw in this every now and then, is race dependent. African Americans have the highest rate of neonatal mortality, followed by Native Americans, Caucasians, etc. One thing is pointed out in your text material and is a great board question as well, is they may throw in a preterm, a 500-gram male. And that 500-gram male, they may ask you for which race has the highest mortality, and it's actually the Caucasian. Less than 500 grams is the Caucasian male, not African American. These are for terms. Now, maternal factors associated with neonatal mortality, teen moms, of course, unmarried, smokers, and a big topic is women with underlying diseases such as autoimmune, diabetes, etc., which we will talk a lot about. Other risk factors, again, being male. Being male is terrible, I think. It's on every list, bad list. Multiples and preterms are obvious neonatal mortality risks. Preterm risk factors. Preterm risk factors, you all know very well, uterine anomalies, cocaine abuse. Ironically, I had a mom just a week ago come in rolled in and told me she had just used cocaine about 20 minutes prior to giving birth to a preemie. So this does happen. Chronic disease, other risk factors, of course, GBS is a big one. We will talk a lot about GBS, and there are a lot of slides for that. Now, preterms, they account for about 12.5% of births, but 65% of all infant complications and 15 to 25% of all deaths. That might be a statistic you might want to remember as far as they account for about 12.5% of all births. Preterm survival globally, of course, less than 1,500 is about 85%. Of course, it's regionally it's different from center to center. Now, preterm survival, again with the male. Independent risk factors for increased mortality. If you're male, if you have a 5-minute APGAR score less than 4, the baby that came in, the mom that came in and didn't have antenatal steroid exposure, if they have hypothermia, persistent bradycardia, or IUGR, are all independent risk factors for increased mortality. And that's a nice little question to remember, those 5-6 things. Now, IUGR risk factors, you're all very familiar with them probably. Of course, smoking, maternal hypertension, malnutrition, placental abnormalities. We're going to go over a couple of these things in the very near future. So this isn't an audience response question, but they may ask, what's the leading cause of infant death? And this is in your core material as well. And remember, it's congenital malformations or congenital anomalies. And they may not have that. They may say they may have a trisomy there, because most trisomies are born stillborn. So or aborted prior to birth. So your first audience response system, this one I thought was funny, and I left this in here. You're notified that a newborn has been just added to your service. He was born 20 minutes ago via C-section at 37 4/7 week gestation for a repeat C-section at term. Why does this cause you to put down the phone and shake your head? Well, your service is not on call. He was not born at term. Since he was born via C-section, he'll be in the hospital for 5 days. Infants born via C-sections have less complicated courses than those born vaginally. Silly question, but just keeps you thinking about what is term and what is not. Very good. Mortality rates. So the reason I brought this up here, I put mortality rates are decreasing and have been decreasing for many, many years, for over 50 years now. And I put President Kennedy's, this was on here previously, President Kennedy Boston Children's Hospital, because in 1963, actually in August of 63, he had, him and his wife had a child that was about 5 weeks premature and died of RDS. And today, of course, that's very unlikely to happen. But that event, and his child lived about 2 days, and that event spawned, the search for surfactant and more information on what exactly is respiratory distress, and back then, hyaline membrane disease. But we know, today morbidity is not decreasing. Morbidity, you have chronic lung disease. More and more preterms are surviving. 23, 24 weekers all the time are surviving with chronic lung disease. They have ROP. It's not uncommon for infants to have grade 2, grade 3, even grade 4 bleeds and survive. Of course, with sequelae, but they do survive. So morbidity is not decreasing. One thing that's been in the literature over the last couple of years and will pop up on the boards is the importance of recognizing late preterms. They want you to know that they have about 2.5 times morbidity than those in terms. We treat them all like they're term, and sometimes, they're 34, 35 weeks. If they're 34 and 0 to 36 and 6, they're late preterm, we say. They'll be fine. Well, they're not always fine. They have feeding issues. They have hypoglycemia issues. You know this because you take care of them all the time. They have earlier onset of jaundice. They have temperature regulation issues. So these are things that the board likes to test on. What kind of morbidity is associated with the late preterm. There's a few slides on the placenta that have to be there. I will point out what I really want you to know and what's a good board testing point. You're all probably familiar, the embryo is basically called the blastocyst, invades the endometrium, and then that outer shell is called a trophoblast. The trophoblast really is sort of the barrier between mom and the baby and the fetus. Well, the outer part of the trophoblast is called the syncytium. That's the key point right there. The syncytium is what's really in direct contact with mom. It basically is how the fetus is getting all of its oxygen and nutrients. The key point here is that there are no major histocompatibility antigens. So it's not going to be recognized as foreign by mom. That's the one takeaway from this particular slide. And I'll show you a picture of this. Now, I know that, I don't know how many of you go to the delivery room, you look at placentas. Some of you may not. Some of you don't even want to go near it. But if you are in the delivery room, put on a sterile pair of gloves and pick it up. Because, you can tell a lot from a placenta. You can look at all the cotyledons in there. You can see if there's, they really can't see infarction, but you can feel for calcifications. There's a lot you can tell. So anyway, for the exam purposes, they want you to know the innermost surface is the amnion and the outer is the chorion. And the way I kind of remember that is because I think I live in California. California's on the outside, so California's out here, amnion is inside. I don't know. That might help you, maybe not. But, if you get a board question and you remember that, that'd be cool. So the placenta is organized into what are called cotyledons, and I'll show a picture of this. And there's basically 15 to 30 cotyledons in a typical placenta, and the maternal blood supply is sort of bathes. There's no direct connection or anastomosis between the fetal and the maternal blood supply. There's sort of a bathing, if you will, and I'll show you that on a nice little picture. So here's kind of a picture of a cotyledon, and up here you have uterine vessels, which blood flows in, and it sort of bathes around this. I hope it came out blue, but it bathes around the syncytial trophoblast, and that's what's really the barrier between the fetus and the mom. And if they were going to test you on anything, it would be that syncytial trophoblast, just to know that's the connection between the mom. And here's a nice little diagram of another cotyledon, if you will, right here, and the blood flow in, and it sort of bathes the fetus, and that's how they exchange of the nutrients. That's probably all they would ask you. Umbilical cord. Oh, there's always a question about umbilical cords and one umbilical artery and what to do. And you get excited because you say, oh, I know, I'm going to order a renal ultrasound. You look down and you don't see a renal ultrasound. What do I do? Well, I know it's 55 centimeters long on average in length, but what else? Well, think cardiac, think trisomy. If you believe it or not, those are very common, and we forget about those things. And it's 3 to 4 times more common in twins. And that seems to always be a question. So that's something to always remember. Some placental abnormalities, including infection, chorioamnionitis, we are going to go over quite a bit. Just touch on it right here for a moment, but we will go over it extensively because there will be many questions on that. So other placental abnormalities, such as you have chorio, accretas, and percretas. Chorio is usually an ascending infection of the amniotic fluid, typically ascending. You have the mom who has a fever. She may have 101, 102 fever. There may or may not be uterine tenderness. Sometimes if you're in the DR, you know if it's foul smelling or not. And there may be fetal or maternal tachycardia. And that's, defined as in a fetus, a heart rate greater than 160. And they will expect you to know that. And I have another slide coming up about heart rates and stuff. And they'll typically be ruptured for more than 18 hours or so. Now, an accreta, another placental abnormality, is basically where you have placenta invades into the myometrium. And you say, well, why does this happen? It's really actually pretty cool, but maybe mom had a previous C-section, and when they suture up at the time, it's nice and tight. But then the uterus shrinks down, and those sutures become loose, and maybe the theory is that the next time she becomes pregnant, there's some scar tissue, and the placenta can attach to that. And then you have an accreta. Or you have a percreta, where the placenta invades into other organs, like a bladder. And of course, there's increased risk for maternal hemorrhage. Now, this is always a great board testing point. An abruption. Mom comes in, stat C-section, rush, she's bleeding, you're called immediately, you're running over there, huffing and puffing, and they drape and gown and get the baby out in 2 seconds, and you think it's an abruption, and everyone's worried that the baby's exsanguinating. Well, you have to remember it's not baby's blood. It's mom's blood. If it's a true abruption, now there are other issues that we're not going to talk about just yet, but for the board purposes, it's maternal in nature. It's not fetal in nature. So don't panic too much. But that's a great board testing point with an abruption. And then a chorioangioma, these are actually fairly common, and many times they're benign placental tumors and nothing to get excited about, but occasionally, about 1% or so, cause fetal cardiac failure or high drops. And you should, and you probably will at some point, look at a picture of a hydropic baby before the exam, because they may just show you a hydropic baby and ask you lots of questions about it. And we'll talk more a little bit in a few slides. So let's talk about twins and their placentas. Twins are, it always gets a little complicated sometimes with twins, but this is why you should go and look at the placenta and touch the placenta when there is a twin born. It's kind of cool. So the membranes can be fused or they can be separate. If the membranes, so they may have what's called monochorionic or dichorionic. They basically have one chorion or two. Monochorionic is that thin, translucent membrane that you feel when you touch it, after the babies come out and you look at the placenta, you lift up this sac and you feel this thin membrane. That's a monochorionic membrane. The most common type of zygotic twins, by the way, are monochorionic diamnionic. That may be something they might want you to know for the boards. And remember, monozygotic twins are identical twins. I just put that on there as a reminder. Some monozygotic twins are dichorionic, but they're not going to ask you about when they separated. And I know some of you are probably eager and thinking, oh, but if they separated between day 3, day 5 to 6, day 12, they're not going to get that picky. They're just going to want you to know that the most common type of monozygotic twin is a dimo. And then they're dichorionic. Of course, you have 2 amnions and 2 chorionic layers. And di twins, dizygotic, are usually associated with fraternal twins. The thing they will test you on is twin-twin transfusion and wanting you to know what type of twins this occurs in. It occurs in about 10 to 15% of monochorionic twins. That they can ask you, and that's fair. Basically, you'll have a set of twins, and they'll have an anastomosis, if you will, between an artery and a vein between the placentas, each of them. You can sort of picture them as each twin living in their own little bedroom, in their own little amniotic sac. And maybe on the placenta, they're sharing some vessels. And what happens is one of the twins becomes a donor twin, and unfortunate for him, he becomes anemic, and all of his blood goes to the other one, and they become they have oligohydramnios. So they'll be known as the stuck twin. So. And I say the stuck twin because when you look on ultrasound, they literally are stuck up against the wall. Now, the recipient twin is usually the polycythemic, the one that's peeing like a champ because he's getting so much blood flow, he has to do something with it, so you become polyhydramnios because they're peeing so much. And they often are the more likely twin to suffer from high drops and congestive heart failure. They both can suffer from high drops and congestive heart failure, but it's more likely to be the recipient twin. And again, I would look at a picture of a hydropic baby and to see so that you can put that in your memory. Now, the treatment they're not going to ask you about, of course, but there's multiple types of treatments, and one of them is antenatal laser ablation, and they're not going to go into that. So let's move on to prenatal care and what to expect. Dating. Well, I started laughing when I read that. I was like, well, I hope they're dating, but you never know. So basically, you need to know it's the first day of the last menstrual period, and everyone knows, you need to do a history and physical. But believe it or not, I did have a board. I remember a question, and it was simple. They were getting at you to do a history and physical. They had all these other options there, but they wanted to do the history and physical, so I laugh about that, putting it in there. It's silly, but remember that, because you get all excited in the heat of the moment and forget that. So antenatal labs, you'll discuss a lot about syphilis, rubella, hepatitis, and all these, and of course an infectious disease. But typical antenatal labs that we obtain are CBC, UA, blood type, of course, HIV, GC, and counseling. Because this is a great question to, on the board, they may want you to counsel the patient. That's all they want. It's a great time to do that. How often do you need to visit? I don't know that they'll test you on this specific, but, ideally, in the first 6 to 8 weeks. But one of the things they may ask is the 16 to 20 week period. And that's where, you're going to be checking for chromosomal abnormalities and elevated AFP. If it's elevated, you're thinking, oh, I have a neural tube defect. If it's low, you're thinking trisomy 21 or 18, not 13. And then, of course, at 28 weeks, that's about when they come in to do their glucose tolerance test, repeat CBC, and maybe ROGAM. So we're going to touch a little bit about Group B strep. They will ask you I would ask lots of questions. This is a great topic. And in 2010, all of the guidelines were revised, so there's been a lot of literature out there for this. So this is a nice little, this is a great place to pick questions from. It is the leading cause of neonatal bacterial infection. All moms are cultured and screened at 35 to 37 weeks, vaginal rectal screening. And the thing they want you to know, and I have a graph later on as well, about prophylaxis. So you're obviously going to prophylact the positive moms, but what about the moms, the other conditions? If they have GBS bacteria during the current pregnancy, and be careful on a question if it says previous pregnancy. It's during the current pregnancy. If they have a previous infant that was in the NICU with a GBS sepsis, that qualifies. Hands down, you don't need to do anything else. You treat, move on. If they have a positive GBS screening culture, of course, unless it's a C-section before labor. Remember that. Now, the one they probably would, more than likely, it would come from here. They're going to tell you that, a mom comes in, you don't know her GBS status, she had limited prenatal care, and she's less than 37 weeks, or she had a temp that was greater than or equal to 100.4, she's been ruptured for God knows how long, something like that. That's probably the likely one. I would know those things. Now, which antibiotic? I did have this on my test. I remember this. They asked which antibiotic. And I'm looking down and I look and I don't see penicillin. No. But yeah, penicillin, ampicillin. If mom's allergic, you want to think about low-risk anaphylaxis if they're low-risk anaphylaxis, cefazolin. But that's not what they're going to test you on either, because one of the more likely things, they're going to say, mom comes in and you don't have sensitivities. You don't have time for that. So the treatment is actually vancomycin. And the 2010 guidelines are in the core curriculum, and there's also a handout somewhere towards the end of this package with some information on that, and we're going to go over that. So who doesn't need prophylaxis? Well, how about those colonized with GBS in the previous pregnancy? No, they don't. Again, GBS bacteria, previous pregnancy, and if they're coming in for a C-section and they're not in labor, this is a scheduled C-section, and they may throw that in there at you. And of course, if they've had negative vaginal and rectal swabs in the last 5 weeks prior to delivery. Now, like I said, the one that might throw at you is the mom that walks in. You have no cultures, and she's 35 weeks. She's been ruptured for 20 hours, and she's got 101 fever. So, yes, you do want to prophylax her, and those are all risk factors. And what if they come in and, now you have the no cultures? Well, how do you treat them? What are you going to do? She's ruptured, she's delivered, or she's about to deliver. You culture mom, you start the antibiotics. She's GBS positive, you continue the antibiotics. If she's negative, you stop them. It's pretty straightforward. But it's that murky first 24 to 48 hours you don't know. So that's where the Vanco comes in. Now, here's another audience response. An expectant mom in your practice has previously delivered an infant whose postnatal course was complicated by Group B strep sepsis. She wonders if there's anything that can be done to lessen the chance of this occurring following this pregnancy. You tell her which of the following. Good luck. Unfortunately, there is no way to lessen the chances that the infant will be infected. She will receive intrapartum prophylaxis on the basis of her history, and depending on the sensitivities, you're going to wait, of the previous infant's Group B strep. So what are you going to decide to do? I think most of you know the answer to that. Yes, see, she's going to get them. She's going to get them because there's a small group of you that answered B, but it's, she had a previous infant who was complicated by GBS strep sepsis. Right there, that's one of the criteria. So, preterm labor. You need to know the definition of preterm labor. It's uterine contractions with cervical changes at less than 37 weeks gestation. And you need to know a prior preterm birth increases the risk. That's a great question right there. Now, tocolysis, I was laughing because I was thinking, what does tocolysis mean, right? Toko in Greek, I guess, means child, and lysis means to dissolve. So you're dissolving the child? I thought, wow, but no. We want to stop. It's crude. We want to stop that preterm labor. And there are multiple methods and ways to do it. We're not going to get into that. They're not going to really, drill on that. They may ask you about mag sulfate, because mag sulfate is neuroprotective for those really premature infants, the less than 34 weeks, or the 23-weeker that walks in the door. Mag sulfate is, neuroprotective for the infant. Not so nice for mom. They usually get sick. And then steroids. We'll talk a little bit about steroids. They probably won't ask you too much on that, other than the fact that, yes, ideally, you would like to get 2 doses of steroids in, and the steroids are really applied to those infants less than 34 weeks gestation or thereabouts. Now, preterm rupture of membranes, membranes rupture prior to the onset of uterine contraction, and if it's premature preterm rupture of membranes, PPROM, less than 37 weeks, you hospitalize, do a physical exam, and vaginal pH testing. They may or may not ask you about vaginal pH testing. They may give you a scenario where you have to know the normal vaginal pH is, 3 to 5, somewhere in there. But if they come back and they've tested and they have a vaginal pH of 7 or 8, well, that's an indication that mom has ruptured if she's more alkaline. That you might need to know. We're not going to discuss expectant versus active management. They're not going to really ask you about all of that. Preeclampsia. You will see moms in scenarios where moms do have preeclampsia, and you need to know looking at how do you categorize them. You categorize them by their signs and symptoms, of course. If their systolic blood pressures are elevated greater than or equal to 160, their diastolics greater than 110, they have significant proteinuria, they may have visual or mental status changes. It's not uncommon for moms to also have epigastric pain and abnormal LFTs, and thrombocytopenia. And that's probably where they're going to start leading you down the road of thrombocytopenia, because they want to get you to recognize HELP syndrome. And you're probably all familiar with it, but it's hemolysis, elevated liver enzymes, and low platelets. You're going to treat the hypertension, of course, with labetalol or hydralazine. And again, one of the questions may be the mag sulfate to prevent seizures in mom, of course, but also it's neuroprotective for preterm infants. Maternal diabetes. I know there's a slew of things here we're going to go through. Maternal diabetes is also a hot topic over the last few years, because many of us, we're all treating babies, IDMs, babies that come in and have a multitude of complications. But you need to know there's an increased frequency of congenital anomalies, and it's the key testing point here. It's related to preconceptional glucose levels. I would put a star around that, because you will see that. That's very likely. They're not going to ask you to memorize fasting blood sugars, but you know them, 60 to 80. And they may throw in a hemoglobin A1C that it should be less than 6. Many of these babies we know are macrosomic. They have to be taken to C-section for either a shoulder dystocia or other complications from secondary to failure to progress. We're going to talk a little bit more about that as well. Fetal well-being, measuring fundal height. I'm not in the clinic enough to know that if people are doing this or not, but this is a topic they wanted you to know, and to measure from the top of the uterine fundus to the symphysis pubis, and you use it to detect IUGR. Now, I'm used to ultrasound. That's what everybody does, right? We ultrasound everything. So at about 20 weeks gestation, you ultrasound and you're looking at biparietal diameter of the head circumference, femur length. They're not going to ask you to differentiate between level 1 and level 2 ultrasound. Level 1 is a general ultrasound. Level 2, for intensive purposes, are just looking a little bit more detail. What they will ask you and will show you are a couple of slides that are coming up. And they may show you some rhythm strips, and that's a possibility. You need to know what a non-stress test is and what contraction stress test, and why are we doing them. We're doing them to measure fetal well-being. You know, the NST is looking at 2 fetal heart rate accelerations within a 20-minute period, and you're looking at fetal heart rate accelerations in response to movement. So it assures us that, you know, if all is good, 99% of the fetuses survive over the next week. If all is bad, well, that's all right. If it's non-reactive, it's not, you know, ominous or anything. You go on to have a contraction stress test, and that look for changes in fetal heart rate in response to uterine contractions. And they tell you, you know, whether you have to have at least 3 contractions, at least 1 minute each over a 10-minute period. The thing they probably might throw you at in a scenario is that mom had a biophysical profile, because this is more common. Mom had a biophysical profile and it's not reassuring. So what they looked at is movement by NST, tone, the reactivity of the baby's breathing, and the amniotic fluid volume. They don't expect you to know amniotic fluid volume levels, you know, but each of those is scored a value from 0 to 2. Maximum 10, and if you get a BPP comes back, and they mention in the scenario it is 1, 2, or whatever, if it's less than 4, that's a mom that you need to consider intervention immediately. A modified biophysical profile is just here for your own knowledge. They're probably not going to throw this at you, but this is where you're looking at the amniotic fluid index, and you're dividing it into 4 quadrants, and that's there for your own enjoyment. So fetal heart rate monitoring. What is it? How do we do it? Who do we do it on, and why? So fetal heart rate monitoring, you know, it's a simultaneous measurement of the heart rate and uterine contractions. You walk into the delivery room in LDR and you hear that thumping going on. That's the fetal heart rate monitor, the Doppler and the tocodynamometer. I can never say that. But and then occasionally you walk in and you'll be surprised and they have a fetal scalp electrode on. And auscultation, I don't know anyone that does that. I've never seen them do that. They may do it when I'm not around. I don't know. And so basically, we're going to look at a couple of strips. And this is probably what you could be tested on, or what, you know, is high yield for the board, what they like. Who are you doing all this on? High-risk pregnancies. So what is a normal fetal heart rate pattern? Normal heart rate is around 120 to 160. That you need to know. They're not going to tell you that. A non-reassuring, well, you know, everything's non-reassuring, but if they're tachycardic, the heart rate's over 160. They're bradycardic. Don't think SLE in your head, because SLE may be one of the choices, and they're just trying to trick you, because SLE you don't think about until after the baby is born, not before. So if they're giving you a heart rate of 60, you know, don't have SLE in your head. Saltatory variability, what does that mean? It just means it's kind of sinusoidal, going up and down. And variable D cells, all sort of non-reassuring patterns. Ominous patterns, you know, get the baby out, is if they're having persistent lates or prolonged severe bradycardia. A sinusoidal pattern. If they show you a sinusoidal pattern, that is get the baby out quickly. Something bad is happening. You know, they're acidotic, they're bleeding, something is going on. So now what? So I said, if you have a non-reassuring, you may do fetal scalp stimulation, and you may get a scalp pH. And the OB may come to you, or in the scenario, they may give you a fetal scalp pH and tell you that it's less than 7.2. And they want you to know that you should deliver that infant. And any time they mention in a scenario that it seems urgent, or it probably is, they're just trying to tell you they want you to get the baby out. So severe bradycardia, what are some things that can cause it? You all know the prolonged compression or prolapse cord. Paracervical block can do it. An epidural, spinal anesthesia can do it. Seizures can do it. That's scary. And previously, a vigorous vaginal exam can do it. So, yikes. Now, some of the questions may come and they may show you, and I'm going to show you a couple examples of early and late D cells. Early D cells are nothing to get too alarmed about. They mirror the uterine contraction and it's usually caused by head compression. If it's a late D cell, we want to think about, oh, is the baby acidotic? Is there something happening going on? And then variable D cells, cord compression, etc. Let's show you an example here. So here's an early D cell, and there we go. So the mom's contraction and the fetal heart rate tones, they sort of mirror each other. So that's a nice little picture they may show you and give you all these ominous doomsday scenarios. Look for the one that says reassuring. Now, late D cells, this is a problem. Here's mom's contraction, and the fetus is a day late. So this is something to be very concerned about because the fetal response is slow. Why is the fetal response slow? I don't know. Maybe he's hypoxic. Maybe he's acidotic. There's something going on that's not right. So they want you to be a little bit more concerned. And maybe end up taking the baby for C-section. Now, speaking of that, some indications for C-section, of course, are if you've had a previous C-section, a shoulder dystocia, fetal distress, malpresentation, or the elusive other. Everything falls into the other category, although they're trying to cut that back now. So the rates have increased significantly over the last few years. I don't have to tell you that, and have come with increased cost and increased maternal morbidity. We'll talk a little bit about VBAC, vaginal birth after a cesarean section. Operative vaginal delivery, using a vacuum. You need to be aware it really should be a maximum of 3 times before, 3 pop-offs when you're in the delivery room, and the board would like you to know that. You also need to know that forceps, they may give you a scenario where the OB used forceps and there may be some bruising or skin lacerations. A variety of things can happen with forceps. Operative delivery and station. This always confused me, and I like pictures of things. I'm very visual, so I will show you a picture of what this means when the nurse comes to you or you see on the scenario and it says, oh, the mom is +2, +3, +5. What is that? I don't know what that is. So I look and I think to myself, okay, well, this is what that is. You have the ischial spine and you have 0 and you have +5 as the head is out. So you kind of get an idea of where you stand. This is a great topic. This is the good stuff, and good questions can come from here. Because simple things like you might forget that oxygenation is on the venous side, not the arterial side. And in the heat of the moment, you sometimes might forget that. But try to remember that, and I'll show you some diagrams. And there are fetal shunts. We'll talk about that. And the fetus you're going to learn in the cardiology, this is no secret, you all know, it's right ventricular predominance, not left. And all fetuses have pulmonary hypertension. It's normal. They should have pulmonary hypertension. And they may try and trick you up. Nice little diagram. The board likes diagrams. So the umbilical vein, and it's in red because it's carrying the highest amount of oxygen, of course, courses through the ductus venosus. And one little key tidbit you'll learn in cardiology, if you haven't already, is that most of the blood is directed through the foramen ovale into the left atrium. And that's a great little board question. They may have some arrows pointing different ways and ask you, which way is most of the blood flow going to go? And it's going to the left atrium. And then left atrium, left ventricle, and out. And why does it go, most of the oxygenated blood go out to the left atrium? Because it has to go to your brain to get oxygenated. So, the 3 branches up here are going to have the highest oxygenation. Hence, that's why you check a preductal oxygenation in the right arm, because that's going to have a higher oxygen. So they may want you to know things like that. And what else do I have here? Oh, right ventricular output is maintained by right to left shunts across the foramen and the ductus, and we'll talk a little bit about the ductus as well. This is a great slide. The next couple of slides are fantastic for good, just nice questions. In fetal life, I just said we all have pulmonary artery hypertension, so your PA pressures are high. Once you're born, bam, they start dropping. And they drop over the next, few weeks, actually. But they drop pretty quickly in the first few hours after you're born. Blood flow will rise significantly as well. And oxygen tension, which is a hot topic, slowly rises. When the baby comes out and he's not a 95% SATs at 1 minute of life, don't panic. It will happen. I promise you they'll go up. These are great questions. Where they may throw at you are some nice diagrams and asking you which baby has pulmonary hypertension, because this is a great question to do that with. You want to see the pulmonary artery pressures. Well, if they have continued PPHN, their pulmonary artery pressures are going to be elevated. Their blood flow is going to be low, and their oxygen tension is going to be in the pooper. There's going to be no oxygen tension. It's going to be very low, and you're going to have a hard time oxygenating them, and that's what they want you to know. So fetal transition and respiratory. The fetal lung is obviously fluid-filled, and it's a non-respiratory organ. And when we breathe, we increase compliance, we increase functional residual capacity, and your pulmonary artery pressures drop. Well, a lot of that, you're clearing a lot of that fluid, believe it or not, before you're even born. So you need to know about 2/3 of the fluid is cleared, about 1/3 when mom goes into labor. Another third of that fluid is cleared through the process of being born vaginally. So about 1/3 is left for you to take care of on your own, if you will, after you're born. Well, if you're a C-section and you weren't in labor, you are likely to retain a lot of lung fluid because you didn't have the process to go through. And it becomes difficult to establish FRC. One of the main testing points of the board, and you probably all know this, I hope so, but you probably do, is surfactant is made by type 2 pneumocytes. That's a perfect question. They're not going to ask you to come up with any equations, but they want you to know it's made by type 2 pneumocytes, and it lowers surface tension. Why do we have it? To avoid end expiratory collapse. So fetal transition glucose. Glucose is another great question, as I mentioned before. Glucose is derived entirely from the mother through placental transfer. You don't need to know it's a GLUT1 receptor, but you do need to know that it's 100% from mom. They will ask you that. So once the cord is clamped, it's completely the baby's responsibility. Obviously, once the cord's clamped, but it's completely baby's responsibility for glycogenolysis and gluconeogenesis. And babies that have low blood sugars also can exacerbate PPHN. So you have a double whammy there. Water balance. The term infant is about 80% of the water is 80% water. 2/3 of it is, which is intracellular. They may show you a nice little diagram about total body water, comparing total body water and extracellular and even intracellular fluid. You need to be aware that total body water and extracellular fluid decrease with increasing gestational age. That's a great little question to put on there with different arrows pointing. So remember, total body and extracellular decrease with increasing gestational age. And early weight loss is primarily secondary to the extracellular fluid compartment. We will do this one question, and I think we will take a break. So fetal circulation is characterized by high left ventricular output, pulmonary hypertension, similar anatomy to that of newborns, or separation of right and left circulatory systems. Awesome. All right. APGAR scores. Who, what, why, where, when, all that stuff. Why APGAR scores came about, you all know. I'm sure most all of you know. It was developed by Virginia APGAR in the 1950s, and she's an anesthesiologist, and she wanted to assess how well babies are doing after they're born. And that's it. Nothing more, nothing less. You absolutely, real high probability of having to calculate an APGAR score. You say, well, it's easy. I do it all the time. On the board, like I said, sometimes you could be a little flustered for time, and there may be, you want to make sure you take your time and don't miss anything. So this you already know, but I would commit it to memory, maybe look at it the morning of or the day before or something. So it sounds simple, but it's an easy point to get and one that you don't want to miss. And the APGAR score, so the question you may get is such that you need to calculate an APGAR score, or why do we do it? It's probably one of those two things. And calculating it, of course, we've laid it out here for you so that heart rate, is it present? If it's absent, you get a 0. If it's less than 100, you get 1. Greater than 100, you get 2. And we do it at 1 in 5 minutes. And the same thing, respirations, muscle tone, reflex irritability. What is reflex irritability? Well, it's really supposed to be tested in response to a catheter, that you're placing in the infant's nose. Are they grimacing? Do they cough? Do they sneeze? Or cry when you go ahead and do that? I'm 95% sure you will have to calculate one. So I would run through a few to make sure you know this, and you can plot it out real quickly because it's a nice, easy point. It does not predict CP. They may ask, why do we do it? And the reason why we do it is because it's just, you want to know how the baby is doing at that moment in time. That's all. It does not have any predilection for CP or anything, and those choices will be there. Don't choose them. Neonatal resuscitation. I love resuscitation, and it's terrible, but I mean, it's one of the things I like to do in the delivery room or you're in the unit. There's certain things you're going to have to know for the board and memorize for the board, and certain things that you take away back to your practice. When what you learn here. So, if the infant is cyanotic and the heart rate's greater than 100, check to see if they're breathing. Sounds funny, but sometimes we forget to put a stethoscope on their chest and we're just looking. But listen. They may require free flow oxygen if they're cyanotic, but yet have a heart rate greater than 100. If their heart rate's less than 100, I don't care whether they're breathing or not, they need PPV, positive pressure ventilation. And that is a great board question. They will give you a baby who is breathing, but just not effectively, and tell you, oh, baby has a respiratory rate of whatever, and has a heart rate that's less than 100. Immediately you should be thinking, I should be looking for PPV. And you want to generally give it, most of you are probably NRP certified. If you're not, you've done it at some point. Things have changed a little bit, but you want to give enough breaths to make the chest rise. Whether you're using a bag or you're using Neopuff, you want to make sure the chest rises, someone's listening. It's common in a panic situation that even the team leader might be missing a few things, and you're over here giving PPV, whether it's a Neopuff or the bag, and you're not giving effective breaths. Goal saturations, 90 to 95%. I should have put a little disclaimer in there, of course, because now on the new NRP guidelines, if you look on most all delivery rooms, you'll see big giant posters with oxygen saturation levels at from 0 to 15 minutes of life. And that's courtesy of some great research out of Australia that's just come about in the last 5 years. But the boards are looking for you to know that, hey, you should be giving oxygen. The goal saturation should be titrated up slowly. But if you're in a resuscitation, all bets are off. Temperature in the DR. The board content had listed this year, temperature in the DR. You need to know what the ambient temperature should be when you walk in. Many times you can go to the delivery room and it's freezing cold in there. Well, imagine if you're bathing in the amniotic fluid, nice and warm, and someone takes you out and you're going to be a little chilly. So, and it sounds funny, but morbidity and mortality increase significantly for every 1 degree change in temperature. So the temperature in the delivery room, they want you to know, should be 73 to 76, 77 degrees Fahrenheit. And many times the OBs, they don't always like it because it's so warm in there, but if you politely remind them that the infant's morbidity goes up, they will quickly fix that for you. Now, endotracheal intubation tube size, they may present this to you in a case scenario or ask you what size tube, how far do you put it in. Less than 1.5 kilo, 2.5 millimeter tube is fine. Some would say if you're intubating with less than a 2, you shouldn't be intubating at all. However, that's a different argument for a different day. They do expect you to know the size of the tubes, and it's fairly straightforward to memorize. And the weight of then how far do you put the tube in? It's the weight plus 6 or 6 plus the weight, and that'll lip to tip, essentially. And sometimes just for your own practice, what I do, if I get called to a stat cesarean section or something and I have everything all prepped and we're all set up, and a good resuscitation is a quiet resuscitation, just to let you know. You really should have one leader and one person communicating with each other one at a time. But anyway, sometimes if the baby's, I put the baby on the warmer and they hand me the endotracheal tube, I'll actually look real quick and I'll have my spot marked out where I have to put my finger so I know I don't go too far, because it's not uncommon. In the excitement of things, we intubate, boy, do we intubate. And you put, and then next thing you know, you have a chest x-ray and you're totally ventilating one lung. And they will show you that on the board. That's another great testing question. They'll show you an x-ray. And they'll show you an x-ray and maybe everything looks fine, but you'll see the baby has endotracheal tube, right main stem, that needs to be pulled back. So that's a nice thing to look for. Sustained heart rate less than 60. If it really is less than 60 and the nurse is telling you it's less than 60, the clinical scenario on the board exam is telling you it's less than 60, you have to think, do you have adequate ventilation? That may be one of the choices, that you're giving inadequate PPV, or you have an inadequate seal on the mask. And what they're looking for is, if everything is done properly, they're looking for you to start cardiac compressions. That if the heart rate is sustained less than 60 for 30 seconds, you need to start compressions despite your good effective PPV. And they will tell you whether it's good effective PPV. Cardiac compressions, 100 to 150 cycles per minute, and the depth is about 1/3 the depth of the AP diameter. And 3-to-1 compression to ventilation ratio. You need to know that. If you don't have NRP, that's fine. This will help you out. These are the basic things they will ask. Epinephrine. They love epinephrine. There aren't many drug doses you'll need to memorize. There's not many we need to memorize at all, because we have nice little cards and NRP cards and etc. But a couple of drugs they will ask you are probably like acyclovir. They'll want you to know the dose. Epinephrine is one of those other doses that they may ask you a proper dose. Epinephrine, as you know, stimulates alpha adrenergic receptors, which increases your heart rate. It's arterial constrictor and increases your blood pressure. It also has beta adrenergic receptors, which enhances contractility. They probably won't go there, but they may go here. And they will give you a variety of doses to choose from. You definitely should memorize that it's 0.01 to 0.03 milligrams per kilo, or 0.1 to 0.3 mLs per kilo, 1 to 10,000. They may throw in 1 to 1,000. I doubt it, but I don't know. And they probably won't ask you a question about endotracheal installation versus IV infusion, because there's a lot of controversy about that, and not a lot of evidence for providing endotracheal epinephrine, because we don't know the dose. We don't know how much. Is it 1 ml good? But 2 mLs? There's not enough evidence out there, so they probably won't ask you that, but definitely know the dose. I would circle that or star that. Bicarb. Usually for severe metabolic acidosis, not in your routine. I want to say routine because what resuscitation is routine. But if you're, have to give compressions for 30 seconds or something and then have a heart rate back and then you have effective ventilation, you're probably not going to have to give bicarb. But and you need to make sure you have effective ventilation when you're giving bicarb. And the dose is 2 MEQs per kilo. There's also another way to calculate based on base excess, but you don't need to know that. Now, glucose. you always need to check a blood sugar. That's one of the things they may ask you. They wanted this just to, if a well baby was in the nursery, a baby who is a feeder grower in the NICU, and all of a sudden it becomes septic. They may be looking for you to check the blood sugar. And if you had to do something about it, you would give 2 to 3 mLs per kilo of D10, followed by continuous infusion. And for your own knowledge, because we do, just to take home with you, many of you know, but when you have a baby that's hypoglycemic and you're having to give repeated boluses and you start an infusion of D10, whatever, and you want to start it at, a GIR, a glucose infusion rate, that's about, a little bit higher than 6 to 8 milligrams per kilo per minute, because many times you'll find people will start it, very low, and that's not enough. The baby needs, an average infant needs a glucose infusion rate of about 6 to 8 milligrams per kilo per minute. Well, if they're an IDM baby and they're hypoglycemic, you need to go a little bit higher, so your IV fluids need to be run a little bit faster than just that. That's just for your own takeaway. Narcotic antagonist naloxone. This is a great one. This is a nice question that they could ask about a mom who presents for delivery, and she is a chronic narcotic user or a chronic drug user, and you decide that the best course of action for this limp, non-breathing baby who comes out is to give him Narcan. Well, that wouldn't be the best choice, because the best choice would be to support the respiratory system and provide oxygen and endotracheal intubation, because obviously one of the unfortunate side effects of giving Narcan to a mom who is a chronic user could be seizures. And another important point is it only has about a 2 to 3 hour half-life. So you have to monitor these babies as well, because they could easily have a respiratory depression shortly thereafter you giving it when it wears off. So that's a good board question. These things happen. Now, dopamine. Dopamine is another good board question about what is the first line drug to use for hypotension, they may ask. And it's not epinephrine, but dopamine. And we use it for hypotension, cardiomyopathy, and the dose, variable, but generally 5 to 10 mics per kilo per minute, which they won't ask you. They'll ask you, they'll want to make sure that it's the first line for hypotension. Now, volume expansion, whether you're in the delivery room or wherever you are in the newborn nursery, or you're on the floor or wherever, volume expansion is generally 10 to 15 mLs per kilo of saline versus blood. We're not going to talk about that. But if they have a suspected blood loss, or if they have, for whatever reason, it's 10 to 15 mLs of normal saline. Now, the newborn exam. They love questions on the newborn exam because you can make up so many. You could just, you can go through and just make a lot. The newborn exam is dynamic. It's constantly changing. You know as well as I do. You go see an infant, and then, 5 hours later, someone else goes to see the baby and they have a murmur, or something else has changed, or, it's very dynamic, constantly changing. And the exam includes the interactions of the baby and the caregiver as well. And they do expect you to know that the first exam should be given within the first 24 hours of life. Physical characteristics. I've put a little star next to a few things. There's a lot to memorize this section, but I would go through and memorize a few things, a few characteristics, and because I guarantee you will get a question on there, and they're going to ask you, how old is this infant? And you'll get it if you just memorize a couple of things about each thing. So we'll talk about lanugo hair, what to memorize about that, the genitals, the soles of the feet, and the creases on the feet. Maybe memorize 1 or 2. Breast buds and ears. They love ears. I would totally know the ears. They love telling you the ears don't flop back. The ears do this. They love that. So looking at lanugo, they want you to know that the entire body is covered with lanugo less than 32 weeks in most infants. Shoulders only at 38 to 41 weeks, and it generally is gone by greater than 42 weeks. That's, general. It's not hard and fast, but
Genitals, looking at the male genitals, they love questions, and I'll throw in a little bit of this. I would memorize one or two of these, and you'll do fine. So, are the testes in the canal? They tend to like, few rugae, and so that, okay, well, now you're thinking much younger infant, so that helps too. If the testes are in the upper scrotum versus the lower scrotum, they generally are pendulous after 42 weeks and a post-term infant. Female genitalia, they'll talk about clitoral prominence, and they'll tell you that labia majora covers the clitoris at 36 to 39 weeks. I would remember just one of those things. I would definitely remember foot sole creases, because this is one of the little tidbits they will definitely give you. And they don't, next time you're in the NICU or you're floating by or whatever, I don't know, go look at a 24, 25 week or whatever, and you'll look and they don't have any foot sole creases. They may have, obviously, 2/3 of the foot will be covered by the time they're 36 to 37 weeks. And obviously the whole thing right down to the heel by the time they're 38 to 41 weeks. I would probably stick in my head, one or two of these things. Up to 31 weeks, they don't have any. I would remember that. Breast buds, they like telling you there's a raised areola. Well, oh boy, when was that? What week was that? Just memorize just one. Just pick it. 34 to 35 weeks. Okay, put away the rest. If you just pick your favorite one there. And that literally putting them all together will be helpful. And the ears. They love, for whatever reason, talking about the curvature of the ear, and the upper 2/3 is an incurve, or the ear is flat, or the cartilage doesn't rebound when you fold it over. So these are all terrific little things to pick from. Again, I would pick one or two of these, and probably just one, and then move on to the next thing, like the cartilage. It stays folded from 24 to 31 weeks, and that's almost intuitive. You would think that. It's just hard to remember, it's at 31 weeks. And then it's thin but springy at 36 to 39 weeks. I don't know that I've seen that question. I definitely have seen the stays folded one. They'll talk about that. Okay, here's an audience response question. During a newborn exam, you notice that the infant is entirely covered in lanugo, has no foot sole crease, has flat, soft ears with no recoil, and has no breast buds. The gestational age of this infant is... All right, fantastic. You'll get it right. Now, a little bit more about the exam. Documenting weight and length and head circumference on growth charts. You should know what's the average birth weight, about 3.4 kilos for infant. What's the average length of a term newborn? What's the average head circumference? These are things you will probably get. You should have already maybe or will get in the general peds section, but I would know them, and I would know growth charts for the term babies. You will definitely see growth charts. And I put in here AGA, SGA, and LGA, and disproportionate growth. You don't necessarily have to remember disproportionate growth, but I would know AGA, SGA, and LGA on a growth chart. Now, examining the newborn, you want to know the state of the newborn, looking at and listening to their cry. They may present to you a great question is, does the infant have a hoarse? The infant have a hoarse type voice? They're trying to get you to think about vocal cord paralysis. And if they tell you ENT came by in a consult that everything was unremarkable, well, then you're thinking other things. Maybe it's hypothyroidism, or maybe it was a NICU baby who was intubated for several weeks and now has some sort of subglottic stenosis or something else going on. there are little clues in the questions to look for, and sometimes they could be subtle. Look for, are they describing a shrill? Because you may think, oh, is this a neurological issue, or is this a neonatal abstinence syndrome baby? And that's what they're trying to get me to think. Again, temperature. Not only do you have to know the temperature in the delivery room, but they like you to know the normal newborn axillary temp of 36.5 to 37.5 or 37.4. And of course, it fluctuates, right? And many times you get called and, the baby is warm because he's been under the warmer without servo control for the last 2 hours and you're cooking them, it happens, or they're cold because someone left the isolette doors open. And now you don't need to know about, well, you may need to know. I don't think you need to know about convection and conduction, et cetera. But, things like that. They want to know you to recognize, is this a real temperature or this environmental? Because if it's real, are you thinking, babies tend to generally become hypothermic, right? And then you have to start thinking, oh, is this a sepsis issue they're trying to get me to think about here? Is the baby hypoglycemic? Is it hypothyroid? I've picked up a couple of hypothyroids in the newborn nursery and in the NICU, and it's simply based on hypothermia. So it does happen. Hyperthermia, we don't see it as much unless they're cooking them, or withdrawal. It does happen with NAS, with babies with neonatal abstinence syndrome. That's not uncommon. They can become a little hyperthermic. You're probably all aware of that. Do they have an adrenal hemorrhage or an intracranial hemorrhage? Now, the skin. This is a great giveaway. They may show you a picture. She could just show you a picture of a baby, and they'll ask you a question about it. I distinctly remember one where they just showed a picture of a newborn nursery baby, and it was had acrocyanosis, and they just ask a question about that. So, if they're covered in green, and you're thinking, oh, it's meconium. It's not, are they pale? Are they cyanotic? And here's another good one. If they're really plethoric and red, and they show you this baby that you might start thinking, oh, it's maybe polycythemia and related to IDM. Think, oh, maybe mom's diabetic. And harlequin vasomotor instability, that's a great picture, actually. You should look that up in Zitelli or one of the textbooks, because that's fantastic. You'll get one kid come in and they, halfway down, they're red over here, normal over here, and everybody's freaking out thinking they have some sort of staph scalded skin or something like that. And it's just a vasomotor instability. Don't get too excited about it. And of course, jaundice, thinking about bilirubin, because if they present to you a kid who is jaundice in the first 10, 12, 24 hours of life, you're thinking pathological, versus if they present to you a baby who's jaundice at 2 weeks of age. Looking at blisters, you should have gotten this yesterday, I believe, great pictures of in dermatology of epidermolysis bullosa. I don't think that it'll be more geared towards the dermatology rather than neonatology. One picture they like to show all the time in the NICU section is cutis aplasia. They'll show you a picture of a baby's skull, and with a little popped out, area of cutis aplasia, basically missing a patch of hair right there. And then they'll ask you, what's in your differential diagnosis, and think always trisomy 13. Whether or not they have ecchymosis or subcutaneous fat necrosis. Someone had mentioned earlier about forceps, and you can see subcu fat necrosis from forceps delivery if it's over the bony prominence of the maxilla, or any bony prominence really. They can have a subcu fat necrosis. Now, the head shapes, they love head shapes. In the core curriculum, there's some great pictures of different types of head shapes, dolichocephaly, scaphocephaly, etc. They love asking about craniosynostosis and the sutures. They may give you a clinical scenario where you feel a ridge on the top of the infant's skull, and maybe give you some CT findings or, something like that. And they want you to be thinking about craniosynostosis. The fontanelles, the anterior mean diameter should be less than 3.5 centimeters, and the posterior is usually about a fingertip in size. If they're giving you fontanelles that are measuring, 6, 7, 8, they'll make it obvious. if they're giving it so that it's so large, you have to start thinking, oh, okay, you have something else is going on here, hydrocephalus, something. Start thinking something else. Capets. I would definitely recommend looking up and knowing a diagram and how to label a diagram with a caput versus a cephalohematoma versus a subgaleal. There are some great pictures out there and diagrams. I didn't, unfortunately, put one on here, and I apologize for that. But remember that caputs are sort of like a baseball cap. That's what I always remember. It covers your whole, crosses the suture line, covers your whole head, and it's basically above the periosteum. You may need to identify that on a picture. That's a good question as well. A cephalohematoma, of course, they don't cross the suture lines, and it's below the periosteum. They may present you, we were talking at lunch about a subgaleal hemorrhage. Subgaleal hemorrhages are scary because they can hold a large volume of blood. They can hold about 260 to 280 mLs of blood, and considering a newborn has 80 mLs per kilo, so that's quite a bit. You will see it. Many times they're subclinical, and they're small. Most often you don't really need to do anything about it. But on a board type situation, they may show you a picture of a baby who has their ears pushed forward, and they'll be significantly pushed forward. And then they'll give you some history of a traumatic delivery or forceps, or perhaps difficult vaginal delivery, something like that. To clue you in and the baby will be lethargic, but those ears sticking forward, that's because there's blood behind those ears, and that whole potential space can hold up to about 280 mLs of blood. So that will definitely change your neurological exam for sure. Skull fractures associated with forceps, you need to be aware that linear are generally benign. You can have depressed skull fractures or basal occipital, which will increase have an increased risk of infection and complication, actually, than the other two. Subarachnoid hemorrhage, intracranial hemorrhage. You guys will probably get a little bit of this in neuro too, and you'll cover this. Subarachnoid is pretty common. If you were to CT scan every infant or 100 infants, you'd probably find quite a few, 10% of them have small subarachnoid bleeds. The ones you need to watch, of course, are the epidural, which are a little bit more concerning, and you need to observe those. If they have a subdural, can occur secondary to breach or stress on the skull, and that's injury to the venous vessels, of course. And it happens with forceps and vacuum as well. And you need to diagnose them via CT and MRI. And I'm not sure that they'll ask you about diagnostics, sending them for a CT in the middle of the night or something, but more so to identify a subdural that may be associated with a forceps delivery. And that may be something that would be, they might just mention casually it was a forceps delivery. Eye exam. They love eye exams. Full-term infant, should have a conjugate horizontal gaze and visual fixation, which is well developed by 2 months of age. They like lid questions. Horner syndrome, lower brachial plexus injury. They present with ptosis, meiosis, and anhidrosis. They may present proptosis, and you have to think about a mass behind the eye or an infection. They like conjunctivitis, chemical versus gonococcal or chlamydial. You'll get that in infectious disease, but certainly know that gonococcal infections occur, 0 to 5 days of life typically, and chlamydial infections a little later. It's not unusual for them to ask about, you need to diagnose with a scraping from the eye, and you'll get that in infectious disease. Ophthalmoscope. Awesome question. They'll just show you a picture of a baby with a leukocoria, and they'll have this white reflex. And that's a great question because they want you to start thinking about retinoblastoma, retinopathy of prematurity, or cataracts. And I would keep those things in my head. Mostly they'll probably be asking about retinoblastoma. The red reflex is, of course, vital for detection of cataracts, glaucoma, retinoblastoma, colobomas. Think about charge syndrome. They may be asking you, presenting other anomalies such as cardiac defects, choanal atresia, or ear anomalies, again, something on that nature. So I would keep that in my head. Preauricular pits and tags. Low set ears, start thinking about syndromes and thinking about urogenital anomalies. They may want you to think about ordering renal studies or a renal ultrasound to look for any anomalies. Now, stuffiness of the nose. This is always a good question because they're always gearing it towards syphilis. Syphilis seems to be very popular on the board. But of course, think trauma or even drug withdrawal, the neonatal abstinence syndrome babies. Choanal atresia. This sometimes can get confusing because they'll present a scenario where, they'll say the babies, when they're relaxed, or they're blue and cyanotic, but when they're crying, they seem to be fine and not cyanotic, but you feed the kid again and then they're cyanotic. I think charge syndrome. That's should come forward to your mind. And you may remember choanal atresia could be unilateral or bilateral. In the mouth, you want to be looking in their mouths and looking, and besides palpating, but looking all the way back to the uvula, because they may have a cleft uvula. They may have no uvula at all. I don't have a uvula, but they may not have one. I don't know, but if it's cleft, start thinking submucosal cleft. If you see a bifid, if you see a bifid uvula, start thinking submucosal cleft. Epithelial pearls, those are, shiny white masses on the gums. They may show you that and just ask you for one of the choices may say reassuring, something of that nature, to reassure the parents. Or is this concerning? Do I need to call a neurologist for this? Do I need to get a neuro consult? Do I need to call somebody? Epstein pearls, ranulas, these are all things you're very familiar with. You probably see them more on a regular basis than I do. But and then, of course, palpate the clefts. You always want to palpate and stick your fingers in there and see what's going on, so you don't miss a cleft. It's true, I've missed clefts before. I actually extubated a baby and realized they had a cleft palate at that point. That's because sometimes they're very small, so you want to palpate. You always want to look. Tongue protrudings, all of these things, they like to put a lot of these things in the questions, and they may say, with Down syndrome, often tongue protruding, but think about hypothyroid or Beckwith-Wiedemann as well. Pierre Robin, as far as that, they usually typically have a small mouth. They're highly likely to have a cleft palate, but they'll have retrognathia. You'll look from the side of their chin; it'll be recessed, significantly recessed. It looks like they have a big tongue. It's not that they have a big tongue and they're choking all the time. It's just that their mouth is just small, and the tongue gets in the way. Teeth, I'm not going to talk too much about. Masses. They like cystic hygromas because you can think about cystic hygroma, and there may be, you're thinking, cystic hygroma Turner syndrome, because they may mention there was a cystic hygroma in utero on fetal ultrasound. Think that in your head. And of course, thyroglossal duct cysts, which are more ventral and midline, and they move vertically when the baby is feeding or swallowing, or with tongue protrusion. So that's nice to look at. Another one they love is Erb's versus Klumpke's palsy. You might just get a picture with a baby who has Erb's palsy. The arm is internally rotated, and you have that waiter's tip position, and they just may show you a baby lying there in the radiant warmer or the isolate with Erb's palsy. You'll need to recognize, is that a lower or an upper brachial plexus injury? Remember, Erb's palsy is an upper brachial plexus, and Klumpke's is a lower brachial plexus injury. Torticollis, again, is a great, another one of those, I would look in a good book and look at torticollis and remember, the head is always turns toward the side of injury. That can get a little confusing sometimes as well, but if you just remember that, you'll be all right. Clavicular fractures, supernumerary nipples, and breast hypertrophy. You guys are probably are very familiar with. The lungs, looking at and listening to their lungs. Excuse me. So, they want you to be able to recognize on the exam, is the baby tachypneic? Is their respiratory rate greater than 60? Is this cardiac related or is this pulmonary related? So think about those things. Or is it metabolic related in your head? Retractions, grunting, nasal flaring, etc. The big one I would say is asynchronous movement. Do I have a pneumothorax, or is there dextrocardia? Is the PMI over here when it should be over here? Breath sounds. They'll give you all of these clues in the questions and tell you whether or not there are asymmetrical breath sounds or not. Here we go. So the cardiac exam, listening for, feeling for PMI. And like I said, it's normally 4th to 5th intercostal space on the left, but they want you to know, they want you to actually, you should pay attention to those things in the question because they may say, oh, it's on the right. Or they may show you an x-ray and the bubble of the stomach is over here on the right. You got to pay attention to those things sometimes. Typical heart rate is 120 to 130, typically in a healthy newborn. If it's less than 80, then I would be concerned. If they're telling you that the baby's heart rate is, 60, the baby may or may not present with a rash, you might want to start thinking about SLE and maternal SLE and associated congenital heart block or hypothyroidism. If they're tachycardic, think fever, hypovolemia, hyperthyroid, or there is drug withdrawal issue. And murmurs can get tricky. You guys will go over murmurs quite well about and differentiating different types of murmurs. The abdomen. Now, an abdominal exam, liver and spleen palpation. We should all be palpating the kidneys as much as possible, but they may present you with a scenario where the infant mom felt the mass, and you're always thinking Wilms tumor. Well, Wilms tumor doesn't present. You're not going to find it often in a newborn. You start thinking renal, GU. Put that in your head. As you got a newborn, polycystic kidney disease should pop into your mind. Delayed cord separation. That's another great question. They always tell you, the baby comes in, is 6 weeks old, and still has the cord attached. Start thinking phagocytic defects. They're not going to ask you which type of leukocyte adhesion deficiency. First of all, I didn't even know there was different types until it was probably a year ago. There are multiple types. They won't ask you. They want you to recognize that it's a phagocytic defect, leukocyte adhesion defect. You can have a plethora of questions come from the abdominal wall defects and gastroschisis, prune belly, omphalocele, a plethora. You may see a picture of just a prune belly. And I would look that up, and it's basically the absence of the anterior abdominal wall. And you see the picture, and you just go, oh, I know what that is. That's prune belly. And then you don't see prune belly because they have another name for it, of which, what's funny? I'm having a mind block and can't think of the name of it, but you probably remember. So I would look that up for sure, a picture of what that looks like. But what they want you to get at is cryptorchidism. They have urinary tract abnormalities, so you need to do some renal imaging. And the name will come to me in a moment. Gastroschisis and omphalocele. These are great questions to draw from because gastroschisis, remember, the defect is lateral to the umbilicus. It's not covered by a membrane. You get to the delivery and the bowel is out and it looks purple, and the nurse is trying to do something with it, and you want to lay them to their side and take a little pressure off and call the surgeon and then ask them what to do. Don't just start wrapping it in wet gauze and things. Ask the surgeon what they like, because they're a little temperamental sometimes, but and omphalocele, it's a defect through the periumbilical defect, but it's covered by a membrane. But be careful, because if it was a vaginal birth, the membrane can rupture. And you could have the organs, you may have a liver, a large piece of liver outside of the body, and you're thinking, oh, that's a gastroschisis because the membrane's not there. But be careful with that. They're not likely to show you that. They're likely to see a picture with the covering of the membrane, and then we'll ask you wonderful little questions about what should be done next with, depending on whether you have a gastroschisis or an omphalocele. What they're looking for you to know is that omphalocele are associated with chromosomal abnormalities, Beckwith-Wiedemann syndrome. And remember, all of these kids have gut malrotation. So it may be just as simple as that. But one of the choices may be you need to send chromosomes. Now, your yield for chromosomes in a gastroschisis is very little. It's I don't know, $2,000 test is probably not worth it unless there's other things going on, and they hint in the question that there's other dysmorphisms going on. I wouldn't send it. But if they tell me it's an omphalocele, I would. Back to genitals. The females, they may show you a picture of imperforate or a imperforate hymen. That's I've missed that before because we don't always routinely look, but when you see it on your exam, and that's a funny thing, I should say that, when I was sitting at the exam, this is true. I was sitting at the exam. The guy next to me was taking an exam for, I don't know, some police thing or whatever, I imagine. But a giant hymen showed up on my screen. True story. It happened. And I was like, oh boy, click, next. But you need to know what it looks like and recognize it quickly. Male penis, if it's less than 2.5 centimeters stretched out, you should be calling your neighborhood endocrinologist. And a great question about hypospadias. You shouldn't be circing these kids. It's not uncommon. They may just show you a picture of hypospadias and then ask you about circumcision, or the parent wants to know about circumcision. And in the immediate period, it's not recommended. And of course, undescended testicles. Maybe it's a good question about how long should you wait. Generally 6 months. You need to call a surgeon at that point. And ambiguous genitalia, you probably like congenital adrenal hyperplasia, most often picked up in the females. The males can get missed, as the endocrinologist probably already told you that. They'll present 4 to 6 weeks of life or maybe a little later into the emergency room, whereas the females, most of the time you can pick them up before they leave, hopefully. Imperforate anus. No lie. This does happen. We're just talking about this at lunch. Newborn nursery, baby hadn't pooped in 2 days. What's going on? Is this meconium? Is this a Hirschsprung's? What's happening? Everyone's concerned. You go to examine the baby and you realize they don't have an anus. Well, for 2 days they sat there with so these things happen too. Because, so on the exam, they'll make it obvious. They'll present you with an infant with trisomy 21 and different features, and maybe they'll have an imperforate anus. Now, meconium, since we're on the topic, usually passes within the first 12 hours of birth. In about 99% of babies, it will be within the first 48 hours. And of course, if we don't see it, we're all thinking Hirschsprung's or some other issue is going on. And we'll talk about meconium plugs and CF and hypothyroidism coming up very shortly. The back, everyone's pretty good at looking at the back. I think if you see a midline hair tuft, or if it's not midline and it's off to the side, that's something to be worried about. And they'll make it obvious on the exam about a myelomeningocele or a teratoma. They won't be subtle about it. I would look at a picture, and there should be one in any textbook you open up, whether it's neurology or newborn care. You'll find one looking at myelomeningocele so that you can identify it quickly. Now, supernumerary digits. They may, it's very common, they have an extra little digit over here, one over here. The one thing you have to remember is that you don't just want to tie it off and then it will get black and fall off. Well, it won't if it has a bone in it. So you need to check first and, get an x-ray and 2 views and just to make sure you're not missing a bone in there, because that does happen as well. The one thing I mentioned that they like are palsies, looking at Erb's and Klumpke's palsies. As always, like I mentioned before, the Erb palsy is an upper brachial plexus. They'll show you a picture or describe the waiter's tip to you, and a Klumpke's being a lower brachial plexus injury. Klumpke's could be a little bit more serious injury and a little bit more long-term. And Erb's, many times they'll resolve, but they may need physical therapy. Now, this was awesome because this happened to me. I was so excited because I always got Ortolani and Barlow, and I still get it confused. I'm not going to lie to you. I don't know, clunk, clink, clunk, whatever. I push down, I know. So I have to look, right? It's true. I look and I see something that looks like this, and I said, what the heck is that? It's Galeazzi maneuver. And it's an asymmetry in the height of the knees. And that is another way you can tell about congenital hip dysplasia. Many of you may know it. I didn't know it at the time. So that's a nice little picture you may see. Looking at limbs, of course, for hypertrophy, symmetry, focomelia, whether they have short limbs, amniotic bands. I would look at a picture of if like an amniotic band around a hand or a limb or something. I would look in any of your favorite books. Now, neurological exam, of course, we discussed you're looking at alertness, are they awake, alert, etc. Cranial nerves and motor functions you'll discuss in neurology, but they love cranial nerves, so I would just review them quickly. A lot of babies have mild ankle clonus. It's not too alarming. Some unique newborn or neonatal maneuvers. I don't expect them to put this in here that you have to do a Dubowitz and figure out what the popliteal angle is, or talk about scarf sign and you're over here stretching them like this and figuring out the gestational age. I'm not sure. It's more neonatology related. Reflexes, you definitely need to know about Moro reflex. And, basically if they have a failure to abduct one arm, they could have an ipsilateral brachial plexus injury. And the Moro reflex is typically absent by 3 to 4 months. Autonomic walking and stepping, these are all usually should be pretty well covered. Suck, swallowing, and breathing, typically matures at about 34 weeks gestation for in the neonate or in the fetus. That's why we always I say sometimes it goes back to the near-term infants that we all have trouble feeding. We have to remember that 34, 35 weeker may have some poor suck, swallowing, breathing skills. Those motor skills aren't quite coordinated yet, and hence that's the way they have trouble feeding. Another thing they love, newborn prophylaxis with erythromycin. Remember, it's prophylaxis for Neisseria gonorrhea, not chlamydia. That they will throw at you. And I just had a case less than a week ago of a baby that was just 2 days of age and had pus squirting out of his left eye. And it was swollen and erythematous, and I thought, well, is this a cellulitis going on as well, or is there a mass back there, or is it just a ball of pus? But, turned out to be gonorrhea. So these things do present, and they may show you a picture of that or describe something to that scenario. Vitamin K has been in the news quite a bit, and it's to prevent hemorrhagic disease in the newborn, and it's dependent on factors 2, 7, 9, and 10, of which you guys probably just went over that in hematology with Dr. Thompson. And hepatitis B. The Hep B must be given to, you must give both the hepatitis B immunoglobulin and the vaccine to infants born to Hep B surface antigen positive moms. That you'll get extensively. You probably know the vaccine schedule much better than I do. And one thing they brought up when I was looking over at the curriculum about for the boards, they wanted to know about cord care and what routine cord care should be. Soap and water, and alcohol, or I have to confess, I tried searching for cord care and high and low, and there's no definitive statement from I couldn't find it. If you could find it, please email it to me. I couldn't find that, but they do list cord care. I'm assuming they mean don't be putting dung on it. I don't know, or tying it around and putting a little quarter on it, and putting it in, or whatever the rituals are. They might mean, counseling parents. That's maybe, I'm assuming, what they meant by cord care. But I would suggest, I tried looking for it and I just couldn't come up with it. Now, circumcision in 2012, the AAP made a statement that the benefits outweigh the risks of the procedure. This is something that you may see on the exam because it's electronic now and they can update it pretty quickly. And they may have a question that it's beneficial because it does, they maybe prevent future HIV or urinary tract infection. So that may be a question on there. It's coming along pretty quickly now that it's electronic. They can update the information fairly fast. Neonatal screening. Glucose is not routinely done, but it is for those babies at risk, of course, like the IDMs, the SGA babies, prematurity, or if they're obviously in distress. The treatment, if it's less than 40 milligrams per deciliter in the first 24 hours, you treat them. If it's less than 50 milligrams per deciliter after 24 hours, you treat them. There is an AAP guideline on how to treat them. They didn't specify on the board content that you need to know that guideline. And if it's less than 40, you feed them. If it's less than 40 again, you start IV fluids. They didn't specify that. I think they wanted you to know that if it's less than 40 milligrams per deciliter in the first 24 hours, you need to treat them. Now, you also need to know hematocrit is not routinely recommended. Other things on neonatal screening, infant blood type. You want to know mom's blood type, RH, and direct Coombs as well. And we're going to talk a little bit about that in a few slides coming up shortly. Now, every state is a little bit different on the newborn screen, but I believe all 50 states they do. As a matter of fact, I know they screen for hypothyroidism, PKU, galactosemia, sickle cell. They may ask a question about that. And last but not least, hearing. No newborn should leave the hospital without having a hearing screen completed, whether it's a BEAR, auditory brainstem, or if it's an otoacoustic emission test. They should not leave the hospital without having a hearing screen done. If they fail, they can go on for further testing, of course, with the audiologist, but absolutely should not be leaving the hospital without it. Now, multiple births. They are increasing in incidence, obviously, because we have assisted reproduction. Moms are waiting a little bit longer. They account for about 2% of all births. And, well, risk, it sort of depends on how much prenatal care. And we know that it's increased risk with preterm births, but the risk is increased with pregnancy-induced hypertension, premature rupture of membranes, placenta previa, polyhydramnios. Now, outcome. Multiple births, not uncommon to have malpresentation, of course, because, it's tight in there, and they not only be malpresented, they may also have some issues with maybe, sorry, blanking on the word, but contraction issues with moving their extremities or something like that. You can have cord problems and cord compressions. It's not uncommon to have congenital malformations, and we all know that many twins or multiple births are born preterm, and triplets, the great majority of them are significantly born preterm. Now, operative delivery. It seems like 50% of twins are born by operative delivery. It seems like it's probably 90% where I'm at. And I'm not sure where the 50 came from, but that's what it says, but it's probably 90. And triplets I've never seen a vaginal triplet birth. just haven't. So I've seen quads, and they're all sectioned. But there it is anyway. Conjoined twins, about 1 in 50,000, not so common. And one other outcome, of course, is fetal growth restriction. Like I was just saying, there's not a lot of room in there. And fetal growth restriction starts at about 30 weeks, give or take, when it starts getting a little bit tight in the uterus. And then birth weight abnormalities. Small for gestational age, I kind of reviewed already, is a birth weight less than 10th percentile for gestational age. And IUGR, this is important to know that they have decreased fetal growth rate. In other words, they're not reaching their potential. And it's pathological, where SGA may or may not be pathological. You have to think about, is this a maternal factor? Is this a placental factor? Or a fetal factor? Maternal, does she have chronic disease? Is she anemic? Is she using drugs, or an infant of a substance abusing mom? Is there a placental issue? Did the placenta not form well? Is there previa or something going on, or just a fetal factor? So again, low birth weight, less than 2,500 grams, very low birth weight, less than 1,500 grams, extremely low birth weight, less than 1,000, and my ridiculously low birth weight is less than 500. Now, IUGR is broken up into symmetric and asymmetric growth. Growth restriction. Symmetric growth restriction, you start thinking about intrinsic factors. This is a chromosomal defect. They typically have their head circumference, their weight, and their length are equally affected. In asymmetric growth restriction, maybe it's an extrinsic factor, like it's a uteroplacental insufficiency or abnormality. And they don't normally have all three growth parameters affected equally. They may have just an abdominal circumference may be just affected. Now, some of the SGA outcomes may include these tiny babies. As I mentioned before, it's not unusual for them to be hypoglycemic, to have immunodeficiencies, of course, or have neurodevelopmental abnormalities. SGA infants are at higher risk for reaching milestones a little later. They could suffer from temperature instability, which is very common. Hence, that's what gets them admitted to the NICU quite often. So on the exam, if you are presented with an SGA infant, start thinking about the hypoglycemia that they may have, or neurodevelopmental impairment, and certainly temperature instability and respiratory distress syndrome. It's, again, not uncommon. Now, IDMs, oh boy. There has been an explosion, it seems like, of IDMs. I'm not sure if it's always been around, or it just seems they all come to our hospital. I don't know. But basically, you have maternal hyperglycemia. One of the questions they will ask, as I stated before, and I will state it again because they will ask you, it's prenatal, it's preconception glucose control is what's really important. It's not that mom has been to the Diabob clinic or Sweet Success clinic or whatever clinic you call it, and she has good hemoglobin A1C control throughout the pregnancy. It's what she did before she got pregnant that really matters, and that's what the board wants you to know. So anyway, we know that maternal hyperglycemia leads to fetal hyperglycemia, and then pancreatic beta cell hypertrophy and hyperinsulinism. And all of a sudden, you have this abrupt cessation of supply at birth because you clipped the umbilical cord and took them away, and now they're hypoglycemic. And there are associated hormonal changes at birth, of which you probably are aware, such as upregulated glucagon, increased epinephrine, increased growth hormone, and eventually decreased insulin. So some of the clinical outcomes: fetal death, sudden fetal death. It is not uncommon in to have a sudden fetal death in a mom who is poorly controlled with a hemoglobin A1C of 12 or 13 or whatever it may be. That tells you right there, if it's that high, her sugars were 400 plus. So that's not uncommon, and they want you to know those risks. They require an increased fetal surveillance and active induction. And this is a great question for counseling. This is a good time to counsel mom. And, for the next pregnancy or whatever it may be, because they may present you with a scenario that says mom had a fetal death and she was IDM. What can she do next time? You need to counsel them about keeping their glucose control before they get pregnant, keeping it under control. Macrosomia, of course, they're all at increased risk of birth trauma and ending up having to be an operative delivery. They have twice the amount of fat after about 30 weeks, and we see these 11, 12, 13-pound babies come to the NICU, and everyone thinks they're nice and healthy. All the family members do, and we just shake our heads and thinking, oh, my God, what am I going to do with this? But you have to explain to parents that they have hypoglycemic issues. It's not uncommon. They'll have a higher billy. They can have respiratory distress. You can get a chest x-ray and you can see cardiomegaly. You can get an ultrasound or echo of the heart and you'll see their interventricular septum is just ginormous. There have been studies done on their brains looking at MRIs, wonderful studies. And that show that the infants of diabetic moms have brain abnormalities, changes in the posterior occipital region of their brain. So they do recover and their hearts recover, but there is an immediate time where they need to be monitored and followed. And I think that's what the board wants you to know is that, it's not just, they're a big 14 healthy pound baby, send them home, that they can suffer from a multitude of complications. Now, again, hypoglycemia, as I mentioned, a blood glucose less than 40, you treat it. And, on the board, they're very likely to present you a baby who is jittery, who has they may have a seizure. They want you to check a sugar, who might be hypotonic. And then these babies need early and consistent monitoring. Unlike the routine newborn, where you don't need to monitor it at all. Other problems associated with IDM babies? Hypocalcemia. 10 to 20% of the infants admitted will have hypocalcemia. And they can have accompanying hypophosphatemia and hypomag. And you need to remember, if the calcium's low, and you probably already know this, if the calcium's low, mag's low, correct the mag first, because you're not going to fix the calcium until we correct the mag. These babies, as I said, they may have jitteriness, seizures. They can have prolonged QT interval. And how are you going to treat them? They're not going to ask you, but for your own knowledge, infusion of 10% calcium. There's a variety of different, but generally calcium gluconate is first line, 2 mLs per kilo, over an hour or so. Now, hyperbilly. Oh, yeah. The IDM babies definitely have hyperbilly, about 30% of them, because they have polycythemia. About 20% of these babies, they're hyperviscous. They may need a partial exchange transfusion if their hematocrit is greater than 65 and they're symptomatic. The AAP has mentioned that it's greater than 65 and symptomatic, not just greater than 65. So the board or any question you may see is if it's 70, and they're not symptomatic, you could watch them. And because if they become symptomatic, then you need to do something and intervene, and of course, do an exchange transfusion. And by symptomatic, obviously, respiratory distress, cyanosis, thrombocytopenia, etc. Birth trauma, that goes without saying. If you're having a vaginal delivery of a 10 or 12 pound baby, they can have a fractured clavicle. It's going to be a problem. And more profound jaundice, of course. Respiratory distress syndrome. You have to remember, insulin has an effect. So these IDM babies, insulin has an effect on surfactant. It blocks the enzyme needed for production. It happens in about 10% of IDMs. That's why you'll see they're in such distress. Congenital anomalies are 2 to 4 times increased. Again, I'm not putting on this there for my health, but the poor glucose control before conception, you will get that question right, I guarantee you. Neural tube defects. VSDs, transposition of the Grady arteries, cardiac defects. They can have small left colon. That seems to be a popular question. They can have caudal regression or gastrointestinal atresias. But the small left colon seems to be a popular one. Now, increased incidence of later obesity and increased incidence of diabetes, true. There is some literature now looking at, you may know more than I do, about infant of diabetic fathers and versus the moms, but they're not going to ask you that, but there's some literature out there on that. So getting back to neonatal respiratory distress. Respiratory distress syndrome, previously called hyaline membrane disease. They won't refer to it as that on the board. It's common in about 1 to 2% of all newborns, and obviously the incidence decreases with advancing gestational age. You know, a 28-weeker is more likely to have RDS than a term infant, although you'll see RDS in big babies. Big baby RDS is not uncommon. It is highest in Caucasian males, and it's basically a surfactant deficiency. Now, they may ask you about surfactant. If like I said before, if they ask you about surfactant, it's probably going to be, where is it made? And it's made in the type 2 alveolar cells. For your own knowledge, the majority of it is dipalmitoyl, whatever, phosphatidylcholine, right? Lecithin is the major component. You'll hear about different apoproteins, surfactant protein A, B, and C, A, B, C, and D. You generally don't need to. You can ask your pulmonologist or the neonatologist later on, but you won't be probably tested on that. Phosphatidylglycerol generally ramps up at about 35 weeks gestation, and most of the levels of surfactant mature by 34, 35 weeks gestation. Surfactant is I'm not sure if I talk about. Okay, I'm not sure if I talk about whether or not how you deliver it, but one of the cool things about it is, because I've studied it and looked at different things about surfactant and brainwave function, is surfactant is, when you give it earlier in a neonatal course, you're more successful, and you'll treat RDS with more success than if you're giving surfactant later. And it's essentially sort of like fluid dynamics. It's really simple, actually. If you take like a bowl of water and you pour some dish detergent in it and you pour it on top, it disperses very quickly, right? You can see it's like oil. It'll disperse nicely. Well, that's the baby who is just born and still has all that fluid on their lungs. So if you're dispersing surfactant very quickly down their lungs, it disperses very nicely. And if you're and then when the baby gets a little older and they're maybe 12, 24 hours of age now, and you're giving surfactant, those lungs are now dry. So when you're giving surfactant, it's not as effective and it doesn't disperse as nice. Hence that's why earlier treatment is works a little bit better. Risk factors, again, if you're male, it's just terrible. If you're Caucasian male, it's the worst. And if you're born via C-section and IDM, or you're a twin, and all of those things can certainly happen. And of course, there's always a family history, and that's something you need to remember. But I would definitely remember the top 3 of being male, Caucasian, and born via C-section. Now, what factors may reduce respiratory distress? I've not seen in the literature as to why these things reduce, because no one knows why. There's theories on it, but we're not going to talk about that. But believe it or not, maternal hypertension, pregnancy-induced hypertension, may actually reduce the risk of RDS. Subacute placental abruption, or even maternal use of narcotics has been associated with lower rates of RDS for reasons I know not. Now, LS ratio, they may throw this at you and ask you. They have a 34-weeker who is going to be born via C-section or vaginal delivery, however, and the OB comes back and tells you he's done an LS ratio and it's greater than 2. Okay, well, that's great, but I'm impressed if they know how to do it. But that predicts mature surfactant functions. The point is they're getting at is they want to make sure you just know that if LS ratio greater than 2. Phosphatidylglycerol You don't need to know, but it ramps up at about 35 weeks gestation. Now, antenatal steroids, they improve respiratory distress significantly. Obviously, we give it to moms generally before 34, who present before 34 weeks gestation. You know, the 23, 24, 25, 26 weekers, or 28, whatever, come in and they're at risk of delivering. You like to get the steroids on board as quickly as possible to help improve lung function. And, we're not going to talk about whether you're giving beta or dexamethasone, but steroids in general, and the boards will use just the term steroids most of the time. They have a better outcome after 48 hours after treatment. And like I said, this use is mostly in 24 to 34 week gestation, and you want to avoid multiple courses. You know, if they've come in at 23 weeks and they're in preterm labor and they are getting their steroids, and then things settle down, and then mom is discharged and she comes back again in 2 weeks later, and then 2 weeks later, you don't want to keep giving the infant or the moms, exposing them to steroids, because they found it's not helpful. Most RDS generally presents within hours. You'll get called from the newborn nursery or a clinical scenario that says this baby's 4 hours old or 6 hours old and is now grunting, nasal flaring, has increased work of breathing, and that you need to know the natural course of RDS peaks at about 3 days of age. So that's always a nice little fact. And diuresis really predicts recovery for these babies. Most of them recover just fine, but they may need a NICU stay for a short stint with CPAP or some sort of respiratory support via nasal cannula or something. Not often will you see the big babies get admitted and have to be intubated and given surfactant, but it does happen. Complications they will like you to know, this is a nice testing point, is chronic lung disease such as BPD and complications with the PDA, because we are now getting away from treating PDAs that are not symptomatic. So a PDA that is, if an infant has a PDA, say a preterm, 30-weeker, baby's on room air, nasal cannula, it doesn't have bounding pulses, doesn't have wide pulse pressures, we're not treating it. We're letting them resolve on their own now. That's a new trend at the moment. I don't know if the boards, how they've caught wind of this or what. I'm sure, but I'm not sure how if they'll ask you that. They may, but I doubt it. Probably more towards related complication of chronic lung disease and BPD. And of course, chronic lung disease and BPD has many definitions, but the most commonly accepted definition of BPD is oxygen dependence, at 36 weeks postmenstrual age. So diagnosis, you will see an X-ray with ground glass appearance, or they will describe ground glass appearance to you. I'm sure of it. They will show you that. So I would look at an X-ray slide of that if you haven't already. And of course, you look at, examine the baby, signs and symptoms. Is the baby grunting? Is the baby nasal flaring, etc.? Now, do you need to do extensive blood gases and looking at, acidosis and all this stuff? The board's probably not looking to go there. They're looking to see if you can recognize RDS on an X-rays or in a description of ground glass appearance is very likely. But being able to think about a differential diagnosis, because it may be sepsis, it may be pneumonia, or a congenital heart disease, which is always pleasant on a question, or in real life, because you could get an infant that is term or near term or even a preemie that now has a murmur and has oxygen desaturations and is nasal flaring and grunting and retracting, and you're trying to decide whether or not is this cardiac or is this respiratory. Well, on the exam, in real life, they might list echo, or do this, that. In real life, we generally do a hyperoxia challenge, and you can subject the infant to getting 100% oxygen for 30 minutes, and you get a arterial blood gas, a preductal arterial blood gas, and if the PaO2 is 300, you don't have a cardiac disease, you have pulmonary disease. You have pulmonary shunting going on, VQ mismatching, not cardiac in nature. It would be cardiac if your PaO2 only climbs by 25 to 50, and it's kind of a whole nother lecture, but to explain the pathophysiology, but it's actually quite simple. But we're not going to talk about that. Surfactant replacement. They won't ask you about types, but you need to know there's natural and synthetic and prophylactic surfactant for infants less than 28 weeks gestational age. And, of course, treatment of established disease. Like I said, they're probably getting you wanting to know that where surfactant is made is probably going to likely be the question. Prophylaxis for younger infants less than 28 weeks, it's like I said, it's better distributed if you give it early. It is costly, and the treatment does expose, treatment exposes only to those with disease. You have poor distribution. And surfactant is not benign. You can have endotracheal tube obstruction. I've seen routine surfactant therapies go awry and a baby coding because of it, because they'll have an obstruction and it wasn't maybe not recognized. I've seen it happen several times. Surfactant also is really cool. Just a side note, published a study showing that surfactant also suppresses brain waves. So because of hemodynamic changes and shifts, a lot of preterm babies don't have autoregulation of blood supply to their brain, and you're waterboarding them. And, what do you think's going to happen? You're going to have blood flow changes, right? Blood flow to the heart's going to change. Blood flow to the brain's going to change. But for another story. Supportive care, make sure you have thermal regulation. They have fluid support. Make sure you don't have a cardiac defect and you're supporting cardiac function. But the board is probably going to ask you oxygen. They want to make sure you're going to give oxygen. A lot of questions, sometimes they'll give you a panic scenario, and they just want you to make sure you choose, to give oxygen first. CPAP and mechanical ventilation, we're not going to discuss too much. The mechanical ventilation, if they do require it, it minimizes volume trauma. You want to allow permissive hypercapnia. A normal PCO2 of 40 and a baby that has respiratory distress is probably not being generous enough. It's okay to allow them to go to 55 on the PCO2. And high frequency oscillator, that scares a lot of people out of the NICU, but they're fun to use and it's really easy. Even despite the machine rattling away, going boom, 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 making all this noise, it's actually a gentler form of ventilation, and it works quite nice. So, respiratory distress syndrome. Let's do audience responses. A, only occurs in preterm infants. B, can be prevented through the use of antenatal maternal steroids. C, is cured following surfactant administration. That would be nice. D, is generally limited to males. Everything is limited to males. And E, none of the above. Let's go back. I have controversy there. It can be prevented through the use of antenatal maternal steroids. And then other people chose none of the above. Well, only occurs in preterm males. We know that's not true. Right? I just said it occurs. We have big baby. You see big baby RDS all the time. Can be prevented through the use of antenatal maternal steroids. Well, it can't be prevented. It's not 100%. Whether you're given 1 dose or 2 doses of steroids, absolutely not. The steroids help mature the lungs, but they don't change the rate of surfactant production. So it's not a preventative full, maybe it's a poorly worded question, but B is a poor choice for prevention. And of course, is cured following surfactant administration. Like I said, that'd be awesome. And it is generally limited to males a lot of times, but you'll often see more males than females. But E really is the better choice. It's really none of these. Now, TTN. Everyone's transient tachypnea of the newborn. Well, the word transient means that it's just that. It should go away, and it generally resolves within, 24 hours or so. I know everyone says, it should go away in 4 to 6 hours, but that's not always the case. you'll see it more often in the near-term infants. This is another one of those complications of near-term infants that you may see. They, again, as I said, they have retained fetal lung fluid, and it's typically a C-section without labor. And that's because, as I mentioned before, if you're delivering vaginally and you go into labor, while you're in labor, about 1/3 the fluid starts being resolved in the lungs through a whole host of dynamics that we don't need to talk about, but about 1/3 of it gets reabsorbed while in labor. Another 1/3 gets reabsorbed and pushed out of the lungs during the delivery process. So, if you're a C-section without labor, that's a lot of fluid that's going to be left on your lungs. And it's not uncommon to look for fluid in the fissures on the chest X-ray, especially in the right middle lobe fissure. You may see that. So persistent postnatal pulmonary edema. Most of these kids are tachypnic. They may have some nasal flaring, mild grunting, intercostal retractions, may or may not have cyanosis. They're usually not working really hard. They're not the kid who's sucking his backbone, sucking his chest to his backbone. Usually not that case. And like I said, the chest X-ray will be hazy, maybe some fluid in the fissures and some flat diaphragms, but no air bronchograms. If they show you an X-ray and you're thinking RDS, the difference is that ground glass appearance is for the RDS baby, not for the TTN baby. Over here, you won't see air bronchograms. And the treatment is supportive. It's oxygen really until they recover, and it is transient. It will go away. It may take a little bit of time. Now, PPHN. I love PPHN. They have this elevated pulmonary vascular resistance after birth that just doesn't go away. And whether or not it's because they were a meconium, they're hypoglycemic, they're sepsis, something else is going on. Whatever the etiology is, their pulmonary vascular resistance should normally decline after birth, and after about the first couple weeks of life it declines. But here it doesn't. And they have right to left shunting. I always got confused. Right, left, right. What is this shunting business? If you think of it in terms of pulmonary to systemic or systemic to pulmonary, it's a little easier. So here they have pulmonary to systemic shunting. Why? Because think about it, their pulmonary vascular resistance is staying high. So you have to push your blood flow from the pulmonary arteries out somewhere, so it goes systemic. So anyway, they have a PDA and PFO and essentially as well, and they are hypoxic. And now it's due to multiple. There's a whole list of etiologies. The board they like meconium aspiration, sepsis, RDS. Those are more common things that are likely to present with PPHN. They may throw at you a congenital diaphragmatic hernia. And that's a great question because they may tell you it's a known congenital diaphragmatic hernia, and whether it's right or left, and you'll learn about all this in pulmonary lecture, is that they have pulmonary hypoplasia of the other lung. So hence they're going to have some PPHN. Hypothermia, if they're cold stressed, will throw them into PPHN. Maternal use of SSRIs, or NSAIDs, of course, it goes without saying, but SSRIs have been pretty well published for, the last 5-8 years or so. And hypoglycemia. And another thing you can do just off the beaten path for your own knowledge, constant IV sticks and PICC line placements and central line placements, which are stressful to the newborn, could also throw the newborn into PPHN. And you could code them, and that does happen. Not often, thank goodness, but it definitely can happen. So basically, it's failure in transition from fetal circulation, and they maintain pulmonary hypertension with right to left or pulmonary to systemic fetal shunting. And they have refractory hypoxemia. They're labile. When you go over to the bedside, these are the babies that they're describing that all of a sudden their SATs are 99, and you're whispering to them, or you open the bed or the isolette, and their saturations just go to 60. And that's because their pulmonary hypertension is very, well, I don't know, lack of other words is labile. You don't have, it's a little tenuous in the beginning. So once you have it under control with nitric oxide, et cetera, which we'll talk about, it helps relax the pulmonary bed. If you're quiet around the babies, it helps relax them. They'll often be tachypnic. So how do you diagnose it? First, get a history. Was there an asphyxial event? Is there meconium? Is there sepsis? Second is the exam. Be careful. This is a great testing point. Again, this one is fantastic. They'll describe a second loud heart sound. And they always, throw in there some sort of ASD or something like that. And you'll learn that with the cardiology lectures. But the second loud heart sound is in PPHN. And why do they have a second loud heart sound? It's because those pulmonary valves are just slamming shut. And we're not going to get into the dynamics of it, but more or less just know that it's a second loud heart sound. The chest X-ray, they may show you a chest X-ray, and it can be clear. Because with pulmonary hypertension, it's not uncommon for them to have, now, if they don't have sepsis or GBS or some pneumonia or something going on, their X-ray could look very dark because they have less blood flow to the lung. And then they'll make it generally obvious for you. They won't make it, terrible. If it's meconium, they'll tell you it was meconium, or you'll see meconium patchy infiltrates all over the place, or a congenital diaphragmatic hernia that they want you to recognize by seeing bowel in one side of the lung field. And an echocardiogram, of course, to diagnose. You don't need an echocardiogram to diagnose it, and they wouldn't expect you to choose that. But of course, it's nice because we can measure pulmonary artery pressures, look for tricuspid regurg. That's the other murmur that you hear. Now, how do you treat it? They want you to know you use, supportive but nitric oxide. You want to dilate the pulmonary vessels. How do you do that? Oxygen. You want to oxygenate them. You want to have goal PaCO2 is a little bit lower, 35 to 45. Alkalosis, they're not going to ask you about this. They're going to ask you about oxygen and probably nitric oxide. It would be first-line treatment. And, of course, systemic flow with dopamine. Many times it's not uncommon for these infants to have to be a little hypotensive, and they'll have more and more shunting, but you want to push the blood flow the other way. So essentially, if you increase their vasoconstrict their systemic circulatory system, you can push the flow a little bit in the opposite direction to get it to go to the lungs. And sedation. Of course, you want to keep them quiet. 5 years ago in the literature, everybody was sedating them and paralyzing these infants and keeping it very quiet around the infants because their pulmonary bed is so reactive. It's so vasoreactive. Just walking by or closing the little isolette door can drop their sats. But now everyone, the theme in the last few years has been, yes, sedation, but not paralyzing them and keeping them awake and, letting them recover, but slowly. Nitric oxide is a smooth muscle relaxant. It works by increasing cyclic AMP. You need to know it's a smooth muscle relaxant. It's rapidly cleared by hemoglobin. And it selectively dilates only the pulmonary blood vessels that are ventilated. It doesn't dilate non-ventilated pulmonary bed. So if you have an issue going on, or there's sepsis or pneumonia or something, and that you have a big V-cube mismatch over here, and maybe the left lobe or something, it's not going to dilate that side of the bed. Some of the complications, of course, you have increased oxidants. You can lead to pulmonary injury and rarely methemoglobinemia. And, of course, with PPHN, if you can't get it under control and you've maxed out all your support with nitric oxide, your oxygen, you still can't get, you still have very poor PaO2s. You have what's called oxygen index, or OI, these kinds of things. Then you need ECMO support and get cannulated and put on VV ECMO. That's pretty standard. You don't see it too much anymore for meconium, but every now and then I see babies having to go on VV ECMO to oxygenate them for a couple of days and see if they can give their lungs some rest. Now, mech aspiration syndrome, this is an awesome question. They always ask something about mom delivers either precipitously or came in and there's unknown meconium and the baby came out and the baby is vigorous but significantly meconium stained. What do you do? And they're going to ask you, bring the baby over, your choices may be bring the baby over to the bed and vigorously suction, or have the OB vigorously suction. If the baby comes out, NRP, it's pretty clear in the newest edition of NRP and has been in the last several editions, the baby comes out and the baby's vigorous, they just have the OB wipe them out. That's all. You don't need to do anything, let them cry it out and that's fine. They'll bring them over to the warmer and take it from there. If the baby comes out and they're floppy, and there's no movement whatsoever, and the baby is limp, and you're holding him like a wet noodle, bringing him over to the bed, that's a baby you're going to want to use the meconium aspirator on and very quickly go down and suck out the mech. That's what they're getting at. Generally, it'll be pretty obvious what they want. Your other choice will be oxygen therapy. That's not a good time to be choosing oxygen therapy. If the baby's limp and floppy like a wet noodle, you need to be bringing them over, and then they're looking for you to endotracheal suction the meconium out. Meconium staining is about 5 to 15% of term births. It can happen antenatally or postnatally because we all know that baby gets stressed in utero. What do? They poop. We get stressed in life. Thank God we don't poop. But they do. Multiple factors to promote passage of meconium in utero. Well, what exactly? Stress, placental insufficiency. Something is going on at that moment. Maybe there's an abruption. Maybe for whatever reason the kid's cord is tangled. Maybe the cord was 100 centimeters long instead of the 55, and he's tied himself into a triple Lundy, knot, and the cord is knotted. You don't know what's going on. You've probably all seen true knots in the cord, and that can cause some issues, and then hence the baby has meconium, and now you have two problems: maternal substance abuse, of course, and anything that really causes fetal distress. So again, as I mentioned, back to delivery room management. If the baby is not vigorous and they're depressed respiratory effort, decreased muscle tone, you want to intubate them. If the baby is vigorous, just clear the secretions from the mouth and the nose. Well, diagnosing is pretty easy. You have meconium or you don't. It's, green baby or not. And the onset is pretty quickly. You don't have to wait around for somebody to tell you. They present respiratory distress. You want to get a chest x-ray. And this is the one you'll see patchy infiltrates on. And they often have air leaks. It's not uncommon for them to have a pneumothorax. Think about it as like a ball and valve effect. The meconium is really rock solid. And it gets into airways, especially the smaller airways, and air can go in, but air cannot come out. And what happens is they can be hyperinflated and they can blow a pneumo. And then they can also blow a pneumo because, in the panic of the situation, maybe somebody was giving them a lot of PPV and you didn't realize you're giving distending pressures of, 30, 40 centimeters of water, or maybe, who knows, you can blow a pneumo like that too. And sometimes you have to do that. Depends on the situation. They want you to know a pneumothorax is one of the complications from mech aspiration syndrome. Treatment, how do you treat it? Well, you want to reverse the hypoxemia and acidosis. You want to give them oxygen. If you have to, mechanical ventilation. If necessary, evacuate, needle aspiration or chest tube. Some of the chest tubes now, once you put one or two in, you can put 3 or 4 in no problem. Surfactant and antibiotics because, meconium, if you're probably aware, may or may not, meconium inactivates surfactant. So if you have a lot of poop in the lungs, poop inactivates a lot of stuff. So surfactant is not a bad idea. And antibiotics, of course, because they're at increased risk for infection. So meconium aspiration. Let's do audience response. A, invariably leads to pulmonary hypertension. B, can be prevented via careful tracheal suctioning postnatally. Or C, is caused by bacteria found in fetal stool. Or D, can occur antenatally.
All right, D, can occur antenatally is correct. You know, it can lead to pulmonary hypertension. It's not invariably, but it absolutely can, and we know that. And it can't be prevented via tracheal suctioning. You know, no matter how much and how quickly you get in there, even if before the baby coughs, they can still have meconium down there that you might not have gotten. And I don't know about the bacteria found in stool. I'm not really sure about that. But air leaks, very quickly, you will see an X-ray with an air leak, whether it's neonatal, whether it's peds, some age, older child, you'll see an air leak. Air leaks occurs in about 1 to 2%. Pneumomediastinum, if they show you a lateral view, they're generally benign. Don't get too excited about it. They don't really, they're usually most are asymptomatic. And some of the risk factors for air leaks include mech aspiration, RDS, congenital diaphragmatic hernia, of course, pneumonia, us giving mechanical ventilation. Most of them, if they're spontaneous, they're often asymptomatic, so you don't have to worry too much. If they're, you know, it's hard to grade. What is 10%? Or the radiologist may say 10 or 15% pneumothorax. What is that? How do they grade that? I don't know. But generally, if it's a smaller pneumo, you don't generally have to worry about it too much. But if the baby's presenting with tachypnea, grunting, nasal flaring, a shifted PMI, that's likely a great clinical scenario on a board question, is to say the baby has his grunting and has a shifted PMI, and they may show you an X-ray. Evident on an expiratory film, yeah, but in the neonate, I don't know how you grab an expiratory film when they're breathing 80 times a minute. You're very good. So how do you treat it? Well, you know, I laugh, but, you know, first do no harm. Well, if you don't have to do a lot, sometimes you just do nothing and just watch them. You know, just watch them and they'll resolve on their own. Oxygen washout, a little controversial right now. They probably won't ask you about an oxygen washout because we're not giving free flow 100% oxygen to these babies. We're titrating it down to keep their maybe oxygen saturation greater than 95%, so maybe that only takes 40% oxygen. Whereas 10 years ago, everybody was just flooding them out and giving them all 100%. Needle aspiration, they may ask you that. About, you know, where to do it. It's above the fourth intercostal space. It's fairly simple to do. And if it's a pneumomediastinum or they mention it's a pneumomediastinum, usually don't have to do anything but just reassurance. That would be the likely choice. Now, hemorrhage, pulmonary hemorrhage, you don't see it too often. You guys don't see it too often. I'll see it in the NICU, and I don't even see it that often. But it happens more so in preterms, if there's an asphyxial event perhaps that happened, or they have some other bleeding issue. I've seen it even with surfactant. How do you treat it? You know, you suction them. And if they're on a ventilator, you turn the PEEP up. Just crank the PEEP on the ventilator. And they may ask you that on that. That's a legitimate question. A baby is on a ventilator, has a pulmonary hemorrhage. What do you do? And they may say, increase oxygen, suction, or, increase the PEEP. That's a legitimate question. You want to crank the PEEP up because you're going to essentially obstruct the vessels. You want to stop the bleeding that way. You'll turn it up to 6 to 10 or whatever. Don't be afraid. I know that seems like it's a lot, but it's better than bleeding to death. And then the other thing you can do is epinephrine down the ET tube, but they won't ask you too much about that. Now, one thing they could ask you and trick you with is the differences between respiratory, like BPD and what's called Wilson-Mickedy syndrome, interstitial pulmonary fibrosis. You'll talk about this probably in pulmonary, but it's basically a preterm who really had no history of RDS and has like a BPD type picture. Most of the time they're less than 32 weeks. They've had zero history of a significant respiratory distress, and it presents at about 1 month of life. They have x-rays that come up with bilateral reticular infiltrates. They look soap bubbly. And it's really treatment is supportive. But the key is that they have no RDS, and that's one of the things they may try and trick you with. GBS pneumonia, this is muy importante. This is a very big section. And they will ask you, as I stated before, we were going to get to this, and this whole section on GBS is important. I would star this for sure. GBS pneumonia, early onset is less than 7 days. It's typically there's pneumonia or sepsis. Later onset is 3 to 4 weeks of life. They present with sepsis, meningitis, or even osteo.
GBS, where does it come from? Well, 20 to 30% of moms or women are colonized with GBS. And so it may come from a colonized mom. It may be an ascending infection, maybe related to chorioamnionitis. Preterms, it could be acquired at birth. It could be from a preterm, or maybe they had a prior affected child as well. How do they present? Most of the time, these kids are sick. They'll present you with a scenario, or even in real life, they within the first 12 hours of their life, they're very sick. They're having respiratory distress. They're septic. They look hypovolemic. They really need. They have full-blown sepsis. You end up getting blood cultures, tracheal cultures to confirm. You can confirm via CSF if that's kind of clinically indicated at the time. Depends how septic they are. They often present with a leukopenia, maybe some abnormal coags. But this graph right here, this is great testing questions. Who should receive prophylaxis and who should not? And we gave you this before. If you're GBS positive from vaginal rectal cultures at 35 to 37 weeks, you need prophylaxis. If you have a history of GBS positive urine during this current pregnancy, you need prophylaxis again. The one is always the infant born with an invasive GBS disease. Mom had 2 years ago, the baby was in the NICU and had that. That's a great one. Or if the cultures are not known, which we don't know many times, and they have any one of the following. If they're less than 37 weeks gestation, they're ruptured for longer than equal to 18 hours, or they have a fever greater than or equal to 100.4. And then, of course, prophylaxis is not necessary for the remaining three conditions. I would know the 2010 GBS guidelines. That's essentially there. There's a lot of footnotes on there. I don't think they'll ask you the footnotes like they do on the immunization schedule, where you need to know every single little footnote. But the GBS guidelines it'll be basically this chart here. And if you memorize that, you'll be in great shape. Treatment. As I said, as I mentioned earlier, treatment is penicillin G. They're not going to ask you the doses. And the duration is a little controversial as well. They won't ask you that. But generally, sepsis 10 days, pneumonia 10 to 14 days, meningitis, of course, 2 to 3 weeks. I'm not going to talk a lot about congenital heart disease because you will get a plethora of it in the cardiology section. We could do a whole nother 5 hours on this alone. This is pretty intensive stuff, but to know the terrible T's, the cyanotic babies, the transposition of the great arteries, the tricuspid atresia, the truncus arteriosus kid who may present with just comfortably tachypnea, at a week of age. I'm sorry, that's the transposition of the great arteries. Tetralogy of Fallot, or a total anomalous pulmonary venous return infant, which always doesn't have to be an infant. I had a colleague whose 16-year-old son was just diagnosed with TAPVR. And how did that? That's crazy, but yeah, 16 years old presented. They thought he had asthma his whole life, and finally he ended up going to the ER just a couple months ago and was worsening. They decided to do a more extensive echo and a more extensive angio, cardiac cath, and he had TAPVR. How is that? But crazy. Left-sided lesions you guys will definitely talk about and should know. Hypoplastic left heart syndrome. These kids with the hypoplastic left heart, they're going to present very early on. This isn't going to be the kid that goes home and it presents at a month of age. This is the kid that's going to present in the first week of age. Coarctation of the aorta, severe aortic stenosis, they're going to present early on. And some common anomalies like ASD, VSD, and PDA. We'll talk about PDA and the treatment because they may ask you about how do you diagnose a PDA. And, of course, we know that it's inversely related to gestational age. The younger you are, the more likely you are to have one. But you don't always necessarily have to treat it. They'll say continuous machinery like murmur. You'll immediately know, PDA. They basically will have a dynamic precordium, bounding pulses. They'll have worsening pulmonary function, wide pulse pressures, and their chest X-ray may or may not have pulmonary edema. How do you treat it? Well, if they're on a ventilator, you can increase the PEEP. That will help decrease your left-to-right shunting or through the duct. Now, the question they may ask is indomethacin. It's a prostaglandin synthetase inhibitor. Some side effects, of course, you have to be concerned about oliguria. dilutional hyponatremia, thrombocytopenia, and intestinal perforation in the real little ones. And of course, ultimately, if you treated them with indomethacin, maybe 1 or 2 courses, and they're not responding, and they still have a large PDA, you can, ligate it. Almost done. GI about meconium plug. Meconium plug and meconium ileus we'll talk about because you guys you should be thinking CF in your head. If you see meconium anything, think CF. 90% of newborns, as I said, pass meconium within the first 24 hours, 99 the first 48 hours. A meconium plug is usually the distal colon, not the ileum, but the distal colon, and it's usually an obstruction. It can ulcerate or perforate. And how do you treat it? With enema, isotonic or a gastrographin enema. Now, who's affected? You have to start thinking, does this kid have Hirschsprung's disease? Is this a hypothyroid or small left colon? They probably won't ask you these, but they want you to know about cystic fibrosis. And also prolonged mag sulfate. If mom was on mag sulfate for tocolysis, and, the infant came out and he's hypotonic afterwards, don't expect his bowels to move very quickly. You can end up with a meconium plug because of that. Ileus, of course, is a lower intestinal obstruction from impaction of that meconium, and it can be associated with an atresia. An atresia typically presents 12 to 24 hours, whereas the meconium ileus will present 24 to 48 hours. But definitely know the association with cystic fibrosis. That, hands down, you need to know that. And basically, as I said, it's an obstruction at the terminal ileum. Meconium ileus, they generally may describe a doughy abdomen, some bilious vomiting, failure to pass meconium, or they may show you a KUB, even with some intra-abdominal calcifications that indicates that had occurred earlier on. NEC, you don't need to know the grading of the different types of NEC. You need to be able to recognize pneumatosis on an X-ray. And what they'll do is they'll give you, it's an inflammatory bowel disease, and it's mostly in the distal and proximal colon, but they'll tell you it's a preterm baby who maybe just started up on, or who has been at full feeds now for 1 or 2 days. So he's been feeding and ramping up on feeds, and he's gotten to full feeds, and all of a sudden he's got abdominal distension, he's got bloody stools, he's apneic. They always present classically apnea, bradycardia, desaturations. It's very typical, but they'll throw in bloody stools. I would look for these kinds of things in a kid that maybe just ramped up on feedings and is at full feeds, and now you're suspecting neck. Pneumatosis intestinalis is pathognomonic. You're not going to be expected to know the Bell staging. Portal air, if you see portal air over the liver, bad. Portal air is no good. Yeah, that's a kid who you need to call the surgeon yesterday. Free air as well. You need to call and get a lateral decube. They may just show you a lateral decube. Remember, always get liver up to get an X-ray to look for air. Treatment, NPO. They want to make sure you know NPO, intravenous fluids, decompression, bowel decompression. Cultures, antibiotics, and your surgeon. Hyperbilirubinemia. You guys will probably get it in the GI, but I'll give it a lot of it here. Hyperbilirubinemia, jaundice, breakdown of RBCs, breakdown of hemoglobin in the RBCs essentially, right? Deposition is in the skin, they turn yellow, and they have yellow sclera. Why is it common in the newborn or a neonate? Well, because they have fragile RBCs, they have a high hematocrit. What's a newborn born with? A hematocrit average is 55, so that's a lot of blood on board. They have decreased bilirubin clearance. They have immature liver. They have increased enterohepatic circulation and uptake. So there's a lot of different reasons to have the hyperbili. The types of bilirubin, there's unconjugated, which is reversibly bound to albumin. That's the majority of it. There's free unconjugated, which is not bound to albumin. That's the one that can cross the blood-brain barrier and cause kernicterus as well. Conjugated, of course, which is water-soluble and excreted via the kidneys. And conjugated bound to albumin, we're not going to worry about that right now. There's a little diagram about where does bilirubin come from. Well, hemoglobin and all this, I don't think they're going to expect you to know that. But what they will know, you want to know, is that bilirubin enters the liver and it's converted to its conjugated form, and then it goes to the intestines and it's either excreted or it's brought back up by enterohepatic recirculation. And newborns have increased, and preterms have increased enterohepatic circulation. Hence, that's why they have hyperbiliary many times. So you either have an overproduction or a reduced clearance. Overproduction, we'll talk about hemolysis very quickly, immune versus non-immune. You guys see this all the time, and we see as far as immune-mediated more now as ABO-type incompatibilities. Rather than the minor group antigens. And occasionally you'll see the minor group antigens. Usually it's the big D, I think is the more common one. RH we don't see as much anymore. Non-immune mediated enzyme deficiencies, G6PD or pyruvate kinase. I've picked up several G6PDs. You probably all have in the routine newborn nursery. And coolest thing, a couple of years ago, I picked up 2 spherocytoses in a week. What is that? I was very surprised. But that one was known. It's not really. It's kind of a but the other one wasn't known, so that was kind of cool. But the things you look for is, they're jaundice. But when you look at their CBC, and I look at all the values on the CBC, I know we don't always routinely do that, but when you see spherocytosis, you think, or if you're suspecting it, you notice the kid's just constantly hyperbiliary. No matter you've got phototherapy, lights going, IV fluids, and they're still high billy. And you look at their CBC, and their MCHC is sky high. It's 35, 40%. And their retic count is high. Start thinking about hereditary spherocytosis and its autosomal dominant disorder. You probably talked about it a little bit, but other things, so decreased clearance. Well, neonates have impaired conjugation. And remember, breast milk jaundice is usually after the first week of life. Breastfeeding jaundice is starvation jaundice, really, right? Your first few days, good luck, you're not getting anything. No wonder why you're jaundice. We're all jaundice. So decreased hepatic uptake. I'll touch on very quickly Gilbert's. I think you pronounce it Gilbert's, but Gilbert's is very common. It's an inherited form of unconjugated hyperbilirubinemia. It's your neighbor who went out drinking last night is now jaundice. That's the guy who's got Gilbert's. Pretty much true. And then there's Crigler-Najjar, and I think that's how you pronounce it, Crigler-Najjar type 1 and type 2. They may ask you to differentiate between the two. Type 1, you have very high unconjugated bili, and the almost complete absence of UDP. I'm not going to pronounce, uridine diphospho, whatever. But they have almost complete absence of UDP. Now, Crigler-Najjar type 2, their bilirubin levels are typically 15 to 20. UDP is non-existent. But the cool thing about this is they respond to phenobarbital. So they may mention that in a question that the baby was not responding to phenobarbital when someone gave it. So then you think, oh, that's type 1. If they respond to the phenobarb, think type 2. And then finally, increased enterohepatic circulation, as I mentioned, is very common. And now the timing, quickly, first 24 hours, always pathological. We all know that. In the second, third, fourth, fifth days, it's physiological. But also think sepsis. They may want you to think about sepsis. If they're presenting a baby that's hyperbiliary and has some respiratory distress, something else going on, it's not just the hyperbiliary. Think about sepsis. After the first week, think about breast milk jaundice, sepsis, galactosemia, hypothyroid, biliary atresia, or even congenital infections that may present at weeks 3 and 4. Some of the laboratory workup, interpretation of the results. Remember, the Butani curve is in hours. You can look at days too, but try, hours. You want to get both a total and a direct bili. If the direct is greater than 2, that is concerning think about biliary atresia or choledochal cyst. Maybe it's an Asian infant. I would think that. I've seen that before. We probably all have. Inborn errors of metabolism and CF. Always get a Coombs test and a peripheral smear looking at retic, looking at your reticulocytes to see if it's elevated or not. It's very helpful. I'm less concerned, and you're less concerned if the retic is 5, because that's normal, versus a retic that comes back 15. That makes me a little bit more concerned. Phototherapy. They want you to know on the phototherapy that there's production, how it works. Okay, there's production of lumirubin, essentially, which is water soluble, right? But what's the best wavelength? You probably all know it's around 440 to 460 nanometers is the typical wavelength. And then the irradiance. They speak of irradiance, with the little you measure you put the baby under the phototherapy lights, and you can measure with the little irradiant, I don't know what the device is called, but generally should be above 30, I think it's microwatts per centimeter squared or something like that. I would look that up. I apologize for not having that. They may not ask you that. They want you to know that expose the area of the baby. Take the cap off of the baby and make sure they're not wearing a hat, and that you're exposing as much area of the baby as possible. Now, complications we see less of, but of course we worry about the retinas, so we have eye coverage. We don't see a lot of insensible water loss because the new lights are very, they're so high, I don't know, high tech. They don't get as hot as the old French fry lights used to. And in temperature, you're not really cooking them under the newer lights. They're a little bit a little nicer. There is an association with opening up a PDA, which is interesting too. That's new out in the literature, but you won't be asked about that. Kernicterus. You will be asked where, and this may be a neurology and a neonatal question combined. They may ask where what part of the brain is affected by kernicterus. Basal ganglia, the geniculate bodies, the hippocampus. That's what they're looking for. And these kids typically present with hypotonia, hypertonia. They can have sensory neural deafness, of course, as you know, you're probably all aware. They may have motor deficits, and of course, die. The highest bilirubin I've ever seen was 45, and the kid died. We couldn't do anything to save him, despite we did a triple volume exchange transfusion. But IVIG, just briefly, IVIG for RH and ABO incompatibility, and as I mentioned, double volume exchange transfusion. You have to be careful with double volume. They may expect you to know some complications of hypocalcemia when you're doing it. Arrhythmias, of course, catheter issues, and portal vein thrombosis. Don't open a catheter. Don't open it to air when you're doing it. You should be pushing and pulling. And erythroblastosis fetalis and HDN, hemolytic disease of the newborn. You're probably all familiar. We're almost done. I apologize. It's basically a maternal antibody against the RBC antigen of the baby, of the fetus. And it's passed transplacentally. So what happens? You have RBC destruction. It's most of the time due to the D antigen. And its sensitization is variable with each pregnancy. That's important to remember. We give moms RhoGAM now at about 28 weeks and then within about 72 hours of delivery. And that's for the moms that are big D minus and the baby's big D positive, because otherwise they can end up with high drops and evidence of, problems with hyperinsulin. But last question, and this is it. Neonatal jaundice is always physiological in the first few days of life, can be accurately estimated via physical exam, that would be cool, is associated with long-term sequelae only if exceeding 25 milligrams per deciliter. It used to be called ventilophobia, right, 20. Must be evaluated in association with postnatal age. And Dr. Bhutani, who's at Stanford, is expecting you all to get this right. All right, great. Thank you very much, and I'm sorry we had to go through that last section pretty quick.